members of the London School of Hygiene and Tropical Medicine Council, Professor Liam Smith, the director of the London School, and other executive team members who are here with us, representatives of the Medical Research Council who are also here with us, led by Steve Oxshott, a director of UNRO, Dr. Okwari, who is also in the audience. Dr. Okwari, I think he was around. Yeah, thank you very much. And obviously, Professor Pontiano Kalevu, director of the UVRI, which is a partner institution that happens to also host the MRC, UVRI, and LSHTM Uganda Research Unit. Esteemed members of our unit's advisory board, led by Professor Paul Kay. He's also here with us with all members of the advisory group. We have a lot of distinguished guests in here, including partner institutions, both academic and other organizations. I want to recognize the presence of Mary, Country Director for CDC. Thank you very much for coming along and for your collaboration. In Uganda, we say all protocol observed because I'll probably forget a few names. But colleagues, partners, and friends, good morning. For me, it's a great honor to welcome you to this joint, it is actually our inaugural conference between UVRI and our unit, the MRC UVRI and LSHTM Uganda Research Unit. It's a rather long name, but it essentially emphasizes the collaboration, the partnerships that we have that bring the unit together. And your presence here today, in a way, is a testament to the strong partnership and shared commitment to advancing health research to benefit not only people of Uganda, but obviously Africa and indeed the world over. So I would, in a particular way, like to show my appreciation to the Honorable Minister of Health, Dr. Cheng, for joining the conference today, and her leadership and dedication for those of us who live in Uganda. Her leadership and dedication to strengthening Uganda's research health systems is most commendable. She's done a fair amount of work in that. As you know, we live in the tropics, not just in the tropics, but actually on the equator, which is essentially a hotbed for viruses. So not surprisingly, we will have outbreaks of Ebola or monkeypox. But the strength of the Ugandan, increasing strength, I should say, of the Ugandan health system is such that these things can be readily contained. So the current Ebola outbreak had 10 cases, unfortunately 2 fatalities, but that's pretty impressive if you can imagine how these outbreaks have been devastating in the past. So the minister has done a fair amount of work to strengthen the systems to make sure that we are better prepared and resilient. And as a unit, we are very proud that we join the ministry in this effort by contributing our research and other activities, response activities to the threats that come our way in Uganda. To Her Excellency the British High Commissioner, we deeply appreciate the UK's continued support to the unit, as well as for global health research in general. And the long-standing relationship between the UK government and the Ugandan government is very strong, and in a way that's what brought about the existence of our unit, because it was upon the invitation by the Ugandan government to the UK government to help with then a very critical challenge of the HIV epidemic right at its peak, that the UK government responded by establishing this unit. And they've continued to support us and continue to support the efforts around health response, health systems, as well as research efforts in Uganda in a very strong fashion. So we are most appreciative of that. And obviously to the London School, Professor Liam Smith and all the leadership, we are very much proud and to be associated with the London School. We absolutely appreciate your leadership and guidance and support, which then makes us continue on our research trajectory in terms of research excellence and global impact. So we have a lot of resources that we've accessed through the units joining the London School, which has made us a much stronger institution and punching out much more than we have been doing previously. And obviously, I would like to acknowledge and appreciate the representatives from the Medical Research Council for being with us here today. The MRC, as you know, is the cornerstone for our success. They bring in that critical funding that is essential for us to undertake our work, and they also help challenge us to shape our research strategy and direction. And they've continued to help us so that we are able to conduct to be one of the centers of excellence for research in Africa and produce some high quality science. And as I said, we have a very strong group of the advisory board led by Professor Paul Kay. They have given us their invaluable expertise and oversight so that we address questions that are relevant, so that our research is at the very forefront of innovation, and that we stand out and that we are distinctive, which we are. So I can go on and on, but basically just to appreciate all the partnerships that are there that bring together the unit and our collaboration with UVRI. I mean, the unit has been there for over 35 years now, and it's been at the forefront of research on infectious diseases as well as non-communicable diseases increasingly, and we are making good contribution to public health as well as addressing the recurring threats in health. So as we look forward, we remain committed to conducting high quality research and to generating evidence that is not just interesting in terms of scientific discoveries, but that informs policy, that strengthens health systems and improves people's lives. So that's the context within which we've organized this conference, to bring an opportunity for engagement in a meaningful way, detailed discussions, exchange knowledge, explore new areas of collaboration, and together I think we can continue to contribute to lasting impact on global health. And once again, I just want to say thank you very much for joining us. Thank you for being here, and I hope that you will enjoy this conference. Thank you very much indeed. And I will now call upon Professor Pontiano, who is director of Uganda Virus Research Institute, who hosts us, to say a few remarks and welcome people to Uganda.
Thank you very much, Moffat. Your Excellency, the Deputy High Commissioner to the Republic of Uganda, the London School of Hygiene and Tropical Medicine Council and SAC members who are here, the leadership of London School, the director, deputy director, and other senior colleagues, representatives of the UK Research and Innovation / Medical Research Council who are here, director of the MRC unit, Director General, Uganda National Health Research Organization, directors, CDC Uganda, and directors of various institutions in Uganda, researchers, very senior researchers who have traveled all the way, who are here with us from different institutions in Africa, in Uganda, in Africa, and in Europe. I see many of you who are here. Colleagues from the Ministry of Health and other organizations, distinguished guests, ladies and gentlemen. I do welcome you to this joint MRC UVRI London School, Uganda Research Unit, and Uganda Virus Research Institute Research Dissemination Conference 2025. The theme, as you can see, is building on our past discoveries, paving the way for a healthier future. In my capacity as director of the UVRI, I want to extend my appreciation to all of you for honoring our invitation to come to this conference. We decided to hold a joint conference to further show our strong partnership between the UVRI and the unit that has existed for near 40 years. Sometimes people ask, what is UVRI and what is MRC? We work as partners. We value this partnership, which allows us to bring together the strength of both organizations that share a common goal and share the physical space. The unit has made great contributions over the years, and some will be presented today, and I've been privileged to have been part of these achievements. UVRI as well is an old institution that was established in 1936. In fact, next year we'll be celebrating 90 years. I hope when we have a joint meeting, we'll be celebrating 90 years of UVRI's existence. And over the years has made a lot of contributions in viral discovery, understanding disease, and working very closely with the Ministry of Health and other partners in addressing our health needs. The Minister, Honorable Minister, who is on our way coming, has been very supportive, and I want to thank her. She has provided us with a lot of guidance and has been interested in our work. I also wish to thank the UK government and other funders for the support they have given both to the unit and to the UVRI. You have heard from Professor Moffat how the unit was established at the invitation of the Uganda government. The UK government came to support in addressing HIV/AIDS earlier on in the epidemic. And we are very pleased to see that since then, this support has continued for all these many years. I would like to thank colleagues from London School, from UK MRC, and from other partner institutions in Uganda and abroad who are here, with whom we have been working for a very long time, supporting not only the unit, but also the Uganda Virus Research Institute. I do recognize many of these partners who have managed to come here, including, of course, CDC and many others from Makerere University and other institutions, with whom we have been working very, very closely. Let us use this opportunity when we're here to network, to know each other, so that we can address the future health needs of our people. I do thank the colleagues who have been involved in the organization of this conference. You have done well, and I look forward to the 3 days we're going to be together. And to all of you once again, welcome to this conference. Thank you.
Okay, thank you very much, Professor Pontiano. I will now call upon the director of the London School, my boss, to come and welcome, give an even bigger welcome than I gave.
Hello everyone. As Moffat says, I'm Liam Smith, Director, London School of Hygiene and Tropical Medicine. Whoa, that's going to fall over. I won't go over everyone, but a very sort of respectful and warm welcome to you all. We're very proud to have the unit as part of London School of Hygiene. It became part of the school in about 2018, and we're very committed to supporting the unit in everything it does and really helping it continue to strengthen as a centre of excellence in sub-Saharan Africa here. It's not an exclusive relationship. In fact, we positively welcome other partners and other partnerships and collaborations across Africa and indeed across the whole world. And I think I'll come back to partnerships in a second, but it's clear that the world is facing some pretty big political challenges at the moment. The Western world being dominated by leadership that is perhaps not as committed as many leaderships have been to equity, to health, in fact, to development internationally. And it can be tempting to give up in times like these. I've had students and younger professionals to ask me, you know, what's the point of trying to work in health and global health and trying to improve health when we're facing these challenges? And I would like to say that I think the opposite is true. I think at these challenging times, I think our mission at the school, and it's one that's shared with the unit, which is to undertake research and innovation that impacts on human health and to train that next generation of health scientists, I think those two missions are ever more important. I think at challenging times where the whole world is facing ever more difficulties and complex issues to do with human health, we need that evidence to underpin policy. We need that evidence to underpin action and the right decision making more than ever. And I think we need that next generation of health scientists to take forward the idea of a healthier world. And so rather than giving up, I think now is the time to reaffirm that mission and reaffirm how important these activities are. Human health is ever changing. The problems we face with human health are ever more complicated. And I think what we need now more than ever is to be working in partnership to try and improve that human health. Those partnerships need to be based on mutual trust and on equity, and I think and hope that that's something that will come out of this conference, ever stronger partnerships, and all of us working together to improve health, not just within Uganda and not just within the region, but across Africa, and indeed undertaking work of global importance. So I'm delighted to see people here. I'm delighted to see this commitment of people to work together and work with the unit into the future. And I hope the next few days are going to be a real success, and look forward to meeting some of you over the next few days. Right now.
Thank you very much. We will now move on to some remarks by Dr. Samu Kware, who is the Director General of Uganda National Health Research Organization, which is the umbrella organization that looks after all the various research organizations, including UVRI. I think we better just wait for the minister. It looks like there is some activity at the back. So, Honorable Minister, you are very welcome. Unfortunately, we broke the protocol a little bit, so you just have to forgive us. but very much welcome, and thank you very much for honoring us with your presence. I was just in the middle of introducing Dr. Okwari to give a few remarks, who is the Director General of UNRWA, which is the organization that looks after all health research organizations, including UVRI and other government entities that lead on research. And Dr. Okwari is a huge partner for the unit, as well as being responsible for activities in UVRI. So we're very happy and honored to have you here. And please welcome give a welcome to our guests and a resounding introduction to the conference.
Thank you so much, Moffat, for those very nice words, so many nice good words. Just a reflection of our collaboration with MRC. Our Honorable Chief Guest, our Honorable Minister of Health, you're most welcome, most welcome. Distinguished guests, the Deputy British High Commissioner at Uganda, you are both most welcome. Our colleagues, our scientists, you're all most welcome. And our collaborators from all sectors, you're all most welcome. And particularly our people in the region, our scientists in the region. I was sitting there with colleagues from West Africa and from East Africa, and a few from Southern Africa, so you're all most welcome. To begin with, Honorable Minister and friends, I'd like to welcome all of you here on behalf of UNRWA. UNRWA is a Uganda National Health Research Organization. It was established by an act of parliament to ensure that research which is done here is used, to ensure that there is equity, to ensure that there is equality and access of health services to the entire populace. I would like to thank in particular the Minister, because she was very instrumental in establishing this act, which has been moving on for the purpose of coordination, for the purpose of alignment of health research, and for the purpose of harmonizing all research work for the benefit of our people. We are here today to see a very important workshop. Important workshop, we will call it a conference jointly organized by MRC and the Uganda Virus Research Institute. A conference which brings many people, many researchers, and many actors and stakeholders together to ensure that there is a exchange of words, exchange of science, exchange of many difficulties and challenges in their fields. MRC has been in the forefront of research in the region. We have been together in areas of innovation. We've been sharing and engaging and offering expertise. And we have also been making outstanding contributions in this collaboration within the country and also within the region, as well as outside the region. Yes, this collaboration has been a very old one. 90 years of marriage is not easy always, except for a few years when the East African community broke up during the time of Idi Amin. But we have been together with MRC from the time of yellow fever, the time of HIV, and now the time of new emerging infections, such as Ebola, such as Marburg, and recently such as COVID. MRC and UVRI have made outstanding contributions in our understanding and control of these epidemics, especially the HIV epidemic. Perhaps I would just like to say that without this collaboration with the MRC, the epidemic in Rakai district would have done tremendous, would have gone out of hand, because the efforts of the Rakai project, the pioneering efforts of Rakai project, were able to identify the transmission, were able even to help us with treatment, and they were even able to help us with establishing our AIDS control program. The actions in Africa are many. Collaboration across the region in many areas. I have just I've just been talking with our colleagues there, from these regions, West, South, and Eastern Africa, who are sharing knowledge, who are sharing opportunities, who are sharing expertise together in a harmonized way with Uganda Virus Research Institute and also MRC. The collaborative efforts have generated a lot of knowledge. They have generated knowledge, but not just knowledge. They have also generated challenges which have been opportunities in moving forward and making our interventions better. We got new knowledge. We have influenced the health policy. I think the minister will know that we have had inroads into public policy, into outbreak management. We have improved health outcomes, and even more importantly, we have shown people that one, health is important, and that when it comes to outbreak, health is not just something for the health sector. Health is something for everybody, for the entire government, in what we now call One Health. So I call upon all of us here to understand this very excellent commitment which has, within the region, which has been able to help a lot of outbreak management and also assure the population there is something called health and the Ministry of Health. We have always excelled when it comes to outbreak management, and we have always excelled when it comes to relieving pain at all levels of healthcare. Now, the Virus Research Institute has actually hosted many national, regional, and also international centers for quality assurance and testing, and also has been a center of training, especially in outbreak management, and also training in laboratory work. For that, we've been very grateful. We've been very grateful to MRC, who have given the necessary support for that very important activity. Today, I think we are here, again, as I said, partners among our partners. Our objective is to ensure that the conference objective is to share the latest in infection control. And two is to provide a platform for improving our work. And thirdly, to ensure that we exchange knowledge. Knowledge which is kept in the pocket, in the cupboard, is not useful. It must be used, it must be generated. Because knowledge is like a child. If it's not nurtured, it gets stunted. And finally, I think we are also here to ensure that this collaboration can be expanded beyond our borders, expanded beyond our region, expanded to encompass the entire international community. The theme for this conference has been straightforward, has been carefully chosen. Basically, the theme is building on past deliveries or discoveries, paving a way for future collaboration, and also ensuring that research leads strategy, research assures capacity, and therefore research also ensures that there's quality both in training and giving healthcare. Ladies and gentlemen, distinguished guests, it's my very great pleasure once again to thank all of you for coming. I'd like to thank you very much and look forward to productive engagements during this meeting. Before I leave the podium, I have been requested by my colleagues that I introduce and welcome the British High Commissioner, who's the next speaker, Deputy British High Commissioner, to come onto the podium and say a few words. Your Excellency.
Hi. Good morning, Minister, distinguished guests. It is an honour to be here. I'm Tiff Curlew, the Deputy High Commissioner at the British High Commission in Kampala, and I bring greetings from my High Commissioner, Her Excellency Lisa Chesney, who would have loved to have been here today, but instead is in the cold and rainy UK, so I think I win this one. Let me start by congratulating MRC, UVRI, and the London School of Hygiene and Tropical Medicine Uganda Research Unit and the UVRI on 35 years of leading science and impact research in Africa and on launching the Joint Research Dissemination Conference, the first one. Your emergence as a regional and global authority at the Centre of Excellence for Innovation, Research and on Global Pathogens, Surveillance and Outbreak Response is outstanding. And I'd like to commend the London School of Hygiene and Tropical Medicine for such a strong and fruitful partnership over the last 7 years. I think we've heard a lot about partnership already today, and I don't think it can be emphasised enough. We are proud of our financial investment to MRC, UVRI, and the LSHTM unit, and what more than 4 decades of partnership has been able to achieve for Uganda's public health sector and for wider Africa. Uganda is one of the great success stories in the fight against HIV/AIDS. Since the 1980s, the unit has provided expert advice to the government of Uganda on HIV prevention and treatment, and engaged in direct patient care and human resource capacity building. Many doctors globally will refer to the unit as the dream workplace, or provide a fond memory or interaction with the scientists from the units during trainings or research collaborations. 2 weeks ago, I had the privilege of touring the MRC and UVRI and LSHTM unit in Entebbe and interacting with the different scientists. It was an absolute pleasure and truly inspiring to see both Ugandan and international scientists putting their best feet forward. I was particularly impressed by the holistic approach that was being taken in all of the research through the social determinants of health lens. I was also excited to know that there were different beneficiaries of the UK's Chevening and Commonwealth scholarships that are involved in different research activities that happen. Are there any here today? I'll come and find you. I spent 4 years at the British High Commission in Nairobi before coming to live and work in Kampala, and I realised that too many times I heard about the cutting-edge medical science and African leadership in relation to Kenya and South Africa. So I feel like Uganda needs to shout a little bit louder. So this month marked 5 years since the official outbreak of COVID-19, and our collective experience has shown us that the global vulnerability to pandemics from novel pathogens is escalating. We are also seeing more and more people around the world suffer from non-communicable diseases like diabetes and early childhood obesity. And in addition to this, our world is still grappling with the old-timers of tuberculosis, HIV and AIDS and malaria. The global political economy is also rapidly evolving in a way that is creating extraordinary fiscal pressures for global public health. And there is an absolute need to build regional manufacturing capability and capacity for the production of rapid scaling of life-saving medical countermeasures like vaccines in the most underserved regions and populations. Research and innovation has therefore become not only imperative, but foundational to protecting human lives, livelihoods and economy. And I want to reaffirm today the UK's commitment to continuing its long and successful partnership with MRC, UVRI and LSHTM Uganda Research Unit, as well as other partnerships that are not directly through the MRC. Should never get a dyslexic to read out lots of acronyms. This week, myself and some of the scientists at the British High Commission will participate in the conference and are excited to hear more about the groundbreaking work that you are all undertaking. We'll also come and participate in the closing session, so you haven't seen the last of us today. As I take my seat, I want to urge us all to continue building on our past successes and seizing future opportunities to pave the way for healthier global population and thriving economies. I think you have exactly the right strapline for what's needed next. Thank you very much.
Thank you so much, Your Excellency, for that very inspiring presentation, remarks. And thank you so much for the support which you have given us over the last 100 years. I think it's very, very commendable. I'm stepping up the podium once again for a very special privilege. The special privilege to introduce our guest of honor. Our guest of honor is Honorable Dr. Lisa Cheng. I think you all know her very well. She doesn't need any introduction. But I think on our side, on the medical side, we know her as a veteran in public health, veteran in disease control, a veteran in the health delivery, and almost, most importantly, a veteran in outbreak management in the whole region and indeed in the whole world, I think. Because recently she got a big award for which we're all very proud. Honorable Minister, we are all very proud of you. You know the ecosystem of health in this country, from the grassroots right up to the pinnacle. And for that, we are very, very grateful for your advice and your leadership. We've all been very quiet. We are very proud of you, and we are quietly very proud of you. We don't shout too. We may be quiet, but quietly, I think we are very proud of you for what you are doing. It's therefore my very simple and very special privilege to invite you to give us your remarks. Honorable Minister.
Thank you very much. Dr. Kware, Director General. Your Excellency, the Deputy British High Commissioner to Uganda, the Director, London School of Hygiene and Tropical Medicine, representatives of the UK Research and Innovation, Medical Research Council, representatives, the London School of Hygiene and Tropical Medicine Council, the Director, MRC, UVRI, and the London School Uganda Research Unit, Director General, Uganda National Health Research Organization, the Director, Uganda Virus Research Institute, senior colleagues from the Ministry of Health, partners at UVRI and other research institutions, members of industry and media, distinguished guests, ladies and gentlemen. It's a great honor and privilege to stand before you today at the inaugural joint MRC, UVRI, and LSHTM Uganda Research Unit and Uganda Virus Research Institute Research Dissemination Conference. This gathering is a testament to our collective commitment to advancing scientific research, strengthening health systems, and ensuring that discoveries translate into meaningful impact for all Ugandans and beyond. For over 90 years, Uganda has been at the forefront of infectious disease research, contributing to landmark discoveries that have shaped global health policies. From pioneering research on viral pathogens to critical work in non-communicable diseases, we continue to demonstrate that investments in science and innovation yield invaluable returns. This conference provides a crucial platform for sharing new knowledge, fostering collaborations, and shaping the future of health research in Uganda, Africa, and the world. As a government, we recognize that science and technology are fundamental to our ability to prevent, detect, and respond to both emerging and persistent health challenges. That is why we remain committed to partnerships that enhance our research capacity and promote knowledge, exchange, and build resilient health systems. The long-standing collaboration between the Ugandan government and the United Kingdom government is a shining example of how strategic alliances can drive scientific excellence and improve public health outcomes. As I begin to conclude, allow me in a special way to appreciate Uganda Virus Research Institute, especially this time for the good work that you're doing in laboratory surveillance for the current Ebola outbreak. When I walked in, I saw everybody very comfortable. Previously, people would be on the edge that there is Ebola in Uganda. Now everybody is relaxed, even when there is Ebola in Uganda. Isn't that amazing? Because everybody knows that Uganda has capacity to prevent, detect, and respond. And that is one of the strengths of the collaborations we have been having and the strength of partnerships that support us in controlling these outbreaks. I take this opportunity to express my profound gratitude to our research funders and partners, UVRI, MRC, LSHTM, and others for their continued investment in our national scientific research sector. Their support has been instrumental in strengthening Uganda's research infrastructure, training the next generation of scientists, and ensuring that our health policies are informed by cutting-edge evidence. Over the next 3 days, we look forward to hearing from leading experts in infectious diseases, and especially as we are all striving hard to end AIDS by 2030. We need to make it a reality. So we want to hear from the experts in infectious diseases, vaccines. There is a lot of drive for local manufacturing of vaccines in Africa, non-communicable diseases, and public health interventions. I hope that discussions not only highlight achievements, but also highlight pressing health challenges. As we explore these vital issues, let us reaffirm our commitment to translating research into action and ensuring that scientific discoveries benefit all. It is now my honor and pleasure to declare this conference officially open. Thank you very much.
Good morning, everyone. As the co-chair of the conference organizing committee, I'd like to also add my welcome and thanks to the Honourable Minister, the Excellency, the Deputy High Commissioner, and to all of you. We're very grateful for your attendance. Just a few points. We're making a slight change to the programme. We've requested Professor Paula Munderi to do her presentation after the break. So we'll go to tea now, but we'd also request, please, that you join us for a group photo. If you just go straight out the back, we will be able to direct you from there. So please do join us for a group photo, stretch your legs, there's tea and some refreshments, and then we'll come back here in half an hour. Thank you.
T, 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 T. Are you good? T, T. T, T. T, T. T, 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 T. T, T, check, 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 check.
Hello, hello. We'll be starting the next session in the next 5 minutes, so please come back into the hall.
Hang on, I tell you what, I might need my glasses. If you could take your seats, it would be greatly appreciated. Welcome back, everybody. I hope you've enjoyed the stretch of your legs and the tea break. I am Sheena McCormack. I'm an Emeritus Professor of Clinical Epidemiology at the MRC Clinical Trials Unit at UCL. And it is my honor, my privilege, and my absolute pleasure to open the scientific part of this conference. So welcome, and we have a tremendous lineup of speakers today. The format is that they're going to speak for 20 minutes, and then there will be 10 minutes for questions. And I've got help from a timekeeper over here, so really grateful if everybody could keep to time and if you come up with your questions. We've also got online audience, so they are also able to ask questions. So I think I wanted to also just say a big thank you to the Honourable Minister of Health and all the speakers who came before for giving us a big start, a great start to this conference. So our very first speaker, I think many of you will know, Dr. Paula Munderi. She is the team lead for HIV prevention, science, treatment, and pediatrics at UNAIDS. And before she joined UNAIDS, she was the Vice President of Programs for IAPAC, the International Association of Providers of HIV Care. And before that, she was a lead investigator on the DART and START trials. So she is extremely well placed to talk to us about the future of HIV innovations. The challenges, and goodness me, we have got challenges to face, and the interconnections. So Paula, I hope you're going to give us a glimpse of a silver lining in the current climate. Welcome, the floor is yours.
Well, thank you, Sheena. If you find a silver lining, let me know. It's oh goodness, yeah, what times we're living in. But thank you very much, colleagues and friends, particularly from my old home, MRC UVRI unit. Thank you for the invitation to be here. Thank you for asking me to come home and take part in your inaugural conference, and congratulations on the inaugural conference as well. So, yeah, coming from UNAIDS, this will be familiar graphic for most of you, and I thought I'd use it. It's the most recent Global AIDS Update report to reflect on the global HIV landscape, which is what Eugene asked me to do, and while we're there, sort of acknowledge some of the progress that we've made so far, and some of the challenges in the global response. Oh, this is supposed to work. Sorry. So that is the distribution of people living with HIV by region. There were 39.9 million people living with HIV worldwide, 2/3 of these in sub-Saharan Africa. I was looking at the computer and it's... Okay. Can I just carry on while I sort it out? Yeah, it's... Thank you, Brian. Sorry.
When they were trying to do it, so because I think there was some...
It's up now. It's up now. Thanks, Sheena. Okay, let's start again. So this is the regional distribution of people living with HIV. And as you can see, 2/3 of the 39.9 million people in 2023 are in sub-Saharan Africa. So we still bear the largest burden, the largest prevalence of the disease. In terms of progress, AIDS-related deaths have declined. And actually, in the report, we say that this is the lowest rate since the 1980s of annual AIDS-related deaths. And in Africa, there has been a rebound in average life expectancy from 56 years in 2010 to 61 years in 2023. But if you look at Eastern Europe and Central Asia, which are other regions of the world, the annual AIDS-related deaths are on the increase. In fact, they increased by 34% in 2023. So it is a mixed picture. A large part of this decline in AIDS death is because of the success of ART. In 2023, we were within shooting distance of the global AIDS targets for HIV treatment. You know, the 95, 95, 95 targets, which mobilized everybody around a common goal of achieving those treatment cascades in the countries. The treatment rollout was not only driving down deaths due to AIDS, but it was also reducing the onward transmission of HIV. And you don't know how happy I am to be able to say this out loud, because that treatment prevents infection has not always been accepted. But now we're acknowledging it because the modeling shows that where the treatment programs are successful, the incidence is also going down. But the provision of ART is unequal among populations and among regions, of course. Children, people from key populations are particularly lacking. On the right is a curve for children, and you can see that diagnosing them, treating them, suppressing the virus is way below what we're achieving in adults. We do not have very good data on key populations, but this graphic is an analysis of the national HIV treatment cascade in Nigeria, and you can see that they're really only achieving about 30 to 40% of coverage, both for treatment, diagnosis, and virus suppression. So moving on to HIV prevention, much more remains to be achieved in reducing incidence. Although we do say that in 2023, fewer people acquired HIV than at any point since the late 1980s as well. And the global response, nevertheless, the global response for HIV prevention was not within reach of the targets that the global public health community set. And I'm sorry that the percentages have fallen off this pie chart, but of the 1.3 million new infections, this is the way they're distributed around the world. Sub-Saharan Africa still accounts for about half. However, there have been significant prevention achievements in Sub-Saharan Africa, much greater than any other region in the world. Maybe it's because we're starting from such a high point. And in other regions of the world, the 3 regions of the world where key populations and their sexual partners continue to be neglected in most HIV programs, incidence is actually on the increase. So it's a it's a plus and minus picture all through, at wherever you look at it. I want to spend a little time on children. How have we done along the journey of ending AIDS in children? What progress have we made? Since 2000, vertical transmission programs averted an estimated 4 million new infections among children. And as you can, if I could go back to the previous slide, the main reason for this is through effectively treating pregnant mothers living with HIV. But providing treatment for mothers living with HIV appears to have plateaued in recent years, and the West and Central Africa region especially is doing much worse than the East and Southern Africa region. But we have good data on what the sources are, what the causes are, and we have good data that we can use to better target program interventions to eliminate vertical transmissions. I think the surprising finding here really has been that there is an increasing number, or an unfortunate number of new baby infections that are due to failed prevention during the pregnancy and breastfeeding period. But also keeping mothers on treatment, finding them and diagnosing them, and keeping them on treatment has to be a major program focus to end pediatric AIDS. Maybe you can move it for me. I don't know. It's not. Ah, okay. There we go. So, moving on from the data, it's not just a service provision. There are other things that we should be doing to support the service provision. And one of the things is that we're increasingly recognizing is that the barriers to service provision, stigma and discrimination, social inequalities, gender inequality, gender-based violence, all these things that make it hard for people to stay free of HIV and to protect their health, and make it hard for them to access services, are as important as the service interventions themselves. People from key populations are especially vulnerable. But while we've increasingly recognize this, it is not reflected in laws or policies and practices. And in this graphic, in this analysis, we show how it's very few countries that actually have an enabling environment. And the example here is from punitive laws, the number of countries that still have punitive laws on their statutes that criminalize either the behaviors of key populations or HIV infection itself. The other target that is off track is community leadership, or supporting community-based interventions and community engagement in the HIV response. And this is particularly sad for the HIV response because communities have been the cornerstone of the HIV response right from the start. The organizations are able to and can provide a range of services, as COVID showed us, but supporting them consistently, while we know that supporting them consistently and engaging them will ensure that our programs survive into the future, it is not happening to the extent that it should. And on this graphic, we are looking at the number of countries who have laws and policies that enable community-led organizations to access funding for their activities, and this is still very much a work in progress. The other service delivery innovation that we really must embrace, especially now, is integrating HIV services into other services. I was giving in the previous slide the example of TB, which is our oldest friend. We've always tried to make the two services run together, but the other infectious disease services, the non-communicable disease services, maternal and child health, sexual and reproductive health programs, these are all things that run with HIV, particularly long-term HIV treatment, long-term HIV prevention. And you know, for such a time as we're in now, it's probably integrate or perish, because we cannot anymore carry on the exceptionalism of the HIV response. While it has responded to the needs of diverse populations, I think we need to overcome anxiety that service integration will weaken this exceptionalism that allowed us to get where we are, and rethink the ways we deliver services using the other service platforms that are available. And the penultimate slide I have is speaking to the big issue in the room, which is shortfalls in funding for HIV response. It was a challenge before now, but now it's like in our face a challenge. Because at the time of the midterm review of the current strategy, we had a funding shortfall. You can see it on the last bar. We knew that development assistance would remain crucial for the HIV response, and we knew that there would be still two major funders, particularly for the health sector, health system strengthening interventions. But at the same time, you can see that there was a base, and these are global data, of course, you know, the devil's in the detail. There was a base of domestic support, domestic funding of the HIV response, which is actually, you know, proportionately quite good. I think when you drill down into those numbers, we realize that the surplus is the costly interventions, the costly commodities, and the costly coordination and implementation support that the HIV response has demanded until now. So, no, Sheena, I don't see a silver lining here, but I am putting some questions on the table for the smart people in the room to reflect upon. So I think I'll leave this here and say that the future of HIV, because HIV is a multi-system disease, clinicians know this, it's a disease that affects every organ system in the body. The response remains a multi-system responsibility. So we need to make nice with not just the health department, the community system, the justice department, social welfare in equal measure. And there are multiple roles in this for researchers, for governments and policymakers, for funders. I've given the state of access to important interventions to prevent, to reduce incidence and to drive down AIDS-related deaths by improving programs. There is a wealth of biomedical innovations, particularly in HIV prevention and treatment, that I haven't addressed, but I know that people coming after me will address them. And the many challenges that I have touched upon, I've concentrated on, are barriers to access to these services. The one thing I'll say about innovations is, you know, there's the new and the old. And as I was just saying to you, Sheena, earlier, I don't believe that we've reaped the benefits of the full scale of, for example, the standard pre-exposure prophylaxis innovations. And here it's not a failing of science, but it's a failing of systems, and it's a failing of service delivery. And we need to solve that in order to go on to the new innovations that could be game changers in the near future. So at UNAIDS, we've started the process of consulting widely for the next global AIDS strategy, which kicks off next year. The vision is that this will be a global AIDS strategy that's driven by innovation, that of course is driven by inclusivity, and eliminating inequalities like the current strategy has been. It's going to be a call to action to redefine what we can achieve together. It's a very changed context. It's a new world in which we are living, new and emerging epidemics, humanitarian crisis, climate change, less money, much less money to work with than we had before. And as we have done before, we shall consult widely. Stand by for us to contact you. We'll consult the global research and public health community, countries, communities, policymakers, funders, and implementing partners. So let me leave some questions on the table if I still have a minute or two. In 2030, there is some modeling that has shown there will still be an estimated 30 to 40 million people living with HIV. They will require care and treatment to remain healthy and virally suppressed while keeping incident infections under control. So even given the 2030 goal, there is 2030 and beyond. That is the future of the HIV response. So I wonder whether this is maybe a time to rethink what we do with a HIV response, how we run it, to rethink the way we deliver services, to reinvent our partnerships, to reimagine the investment in the HIV response. What would the future look like if the global community gave everything they have to the search for that elusive, effective vaccine or a functional HIV cure? I do not have any of these answers, but I'm just putting these questions on the table because I think this is a time to reflect and imagine differently if we dare. Thank you very much.
I'm not sure you can escape. There might be a question. I am so glad you brought up the exceptionalism because I think perhaps that is something we need to be more innovative about in the future. Within UNAIDS, and excuse my ignorance here, within the whole United Nations, is there a possibility of integrations there that might accelerate and help that?
You do ask a tough question.
I'm sorry.
No, I'm going to say absolutely yes, because UNAIDS is a joint program. It was conceived as a joint program, and there is integration. There are different partners who have different, different bits of the response that they focus on. So WHO, UNICEF, UNFPA, the World Bank, UNDP are all members of the joint program, and I'm forgetting like 2 others, there's 7. So there is already integration of ideas, and that's how the joint program was conceived to start with.
Sounds good. Any questions from the floor or online? Thank you, Paula. It's a great start. Thank you. So, and thank you also, Paula, for your patience with our technical glitch. So now I'm introducing Professor Pontiano Calivo, who, as you know, is the director of UVRI and head of the viral pathogen theme at the unit. And in case you didn't know, he represented Uganda at tennis. Isn't that true, Pontiano? It's a secret I happen to know, which many of you may not. Anyway, he needs no introduction, as you know, and he's coming to talk to us about understanding the HIV epidemic. Pontiano, let me check everything. Oh, okay.
Okay, thank you. Thank you very much. I'm going to talk. I think so. I'm going to talk about understanding the Uganda HIV epidemic. And this is going to be the outline of my presentation, the start of the epidemic, the early government response, the contributions of different programs and institutions in addressing the pandemic, the work of the MRC unit in describing the epidemic and disease in the rural population, the early pre-art interventions, the epidemic in key populations, understanding the local HIV strains and immune responses, ALT intervention, including HIV as a chronic disease, drug resistance and others, HIV vaccine research, some of the most recent findings and the future. So there will be a lot of history in my presentation, but I'll be referring to some of the more recent data by referring to some of the posters and some of the presentations that will be given during this conference. So it will be a lot of history or data, but to give you where we have come from and also to tell you where we're moving. I'm very happy that in this audience we have many people who have been part of this history and also some of the young people who are now leading the research and looking at the future. You all remember that AIDS was first identified in 1982 in the southern district of Rakai district, and one of the people who are involved, Professor Nelson, is here in describing the disease known as slim disease in that area of Uganda, as you see in the map. But I think there were a lot of missed opportunities between 1980 and 86, partly because of the civil war that was ongoing, and not much was said about this. And also, I think people initially thought this was witchcraft. So we lost opportunities. The virus was discovered in 1983 as HTLV3. And in that Lancet publication, which described the HIV/AIDS slim disease, it identified as a risk factor, most likely heterosexual transmission was responsible. When the war ended, 1986, it gave opportunity for the government to talk about HIV/AIDS and invited international community to come and control the HIV epidemic. The early epidemic, the National Silo Survey, and I'll talk about the AIDS control program, which was led by none other than Dr. Sam Okwari at that time, did a national Silo survey that gave an average prevalence rate of 9% in the adult population. But in others, like sex workers, 86%, lorry drivers studied about 33%, 40% in blood donors, 15% in antenatal clinics, in urban centers were also positive. The AIDS control program was started in 1986. Dr. Sam Okwari was the first director of that program that did a lot of work, put together strategic plans to control the epidemic, including especially behavior change. We all remember zero grazing and ensuring that people understand the epidemic, and also they put up programs to reduce transmission through blood transfusion, screening, surveillance, and of course, operational research projects. The UVRI were lucky that was it identified as the National Reference Lab for HIV testing in 1987, and through the SCP, and a lot of the funding that really helped UVRI to take on this responsibility came from the UK government, through the then known as the Overseas Development Administration, funds given to SCP through WHO. They provided funding to UVRI to take on the role of a reference lab. I was a beneficiary. When I joined the UVRI in 1989, I was sent to the UK through this funding to study immunology. So I'm part of that support today. TASO, everyone remembers TASO, which was created in 1987 by a group of medical workers who had witnessed how badly patients showing signs of AIDS were being treated and on the wards. And this TASO has continued up to today, providing a lot of very, very good services to HIV-infected individuals. The AIDS Information Center, set up 1990, as a non-government organization in Uganda to provide voluntary counseling and testing for HIV, and opened up branches in different parts of the country. And this AIDS Information Center was very well known here in Uganda. The Uganda AIDS Commission was set up in 1992 under the Office of the President so that AIDS is addressed as in a multi-sectorial approach, and the AIDS control program units were set up in different line ministries and did a lot of work. We started seeing the reversal of the HIV epidemic through behavior change and the interventions that were already addressed by different organizations led by SCP and others, Ministry of Health. And these figures may be small, but one of the studies that showed the decrease in the HIV seroprevalence in the young adults was done by the MRC, and one of the authors of this work, Dr. Jane Kengea, is here with us as one of those, who provided this information very early on that we're beginning to see some decline in seroprevalence. But this was also reported by UNAIDS, SCP, and others. And this was largely attributed to the response, behavior change with the national and international support. What has been the contribution of the different programs? As I said, Uganda was open, invited many international partners to come and address the HIV epidemic. And let me briefly present to you some of these partnerships and their contribution. The first one is the Rakai Project, now the Rakai Health Sciences Program that was established in 1987 as a collaboration between the researchers at Makerere University, Columbia University, Johns Hopkins, Uganda Virus Research Institute, and the Division of Intramural Research at the National Institute of Health, Institutes of Allergy and Infectious Diseases. Rakai was established one of the initial rural cohorts that ran for many years. Some of the outputs included showing that mass STD treatment does not lead to the decline of HIV incidence, showing that the efficacy of medical male circumcision in reducing HIV infection, and the proof that viral load levels are a major factor in HIV transmission. And Professor Nelson is one of those who initiated this program. The Uganda Makerere University Case Western Reserve University, established in 1988, with funding from NIH again, to better understand the new HIV epidemic, but also to undertake capacity building in Uganda through research, training, and mentorship. A lot of work has been done by this program, especially in HIV and TB, including studies that led to the early inclusion of isoniazid in the prevention therapy in the treatment regimens for people infected with HIV. Now it's part of national and international TB prevention regimens. The Makerere Johns Hopkins program that was established in 1988 as a collaboration between Makerere and Johns Hopkins has done a lot of work to study the mother-child transmission of HIV. You all remember the studies of nevirapine that allowed us to prevent HIV transmission in children, the very well-known EVNET 012 protocol. More recently, they have been involved in long-acting cabotegravir, a highly effective prevention that is highly effective in the prevention of HIV in adolescent females, and also other injectables like lenacapavir in PrEP that is very highly effective in the prevention of acquiring HIV in women. We have worked with them, on the first HIV vaccine in children. The MRC program was initiated in 1988, as you have heard, at the invitation of the Uganda government, working the UK government, and I will say more about this program later in my presentation. The Joint Clinical Research Center, established in 1990 as a partnership between 3 ministries to address HIV/AIDS, special care, the Ministry of Health, Ministry of Education, and the Ministry of Defense. And the institution has done a lot in collaboration with Makerere University College of Health Sciences, research, we have done a lot of research together. The DAT trial you've heard about, ART trial, studies on the ART, and more recently, studies on injectable cabotegravir and other care treatments. We have worked with them in studying HIV drug resistance and also in conducting the first HIV vaccine study. And you'll hear more about the work from Dr. Francis, who will be presenting some work. The UVRI program set up in 2001, which I was part of initiating, has conducted the second HIV vaccine trial in Uganda and has conducted a lot of work. And more recently, was part of a number of studies of using long-acting PrEP in the prevention of HIV transmission. The Makere Water Reed Project, is established in 2002, has done a lot of work in HIV vaccine and also in understanding the molecular epidemiology of HIV in the country. The Infectious Diseases Institute in 2002 that has contributed a lot in studies in patient management of HIV, including treatment of opportunistic infections and delivery of ART. The Uganda Virus Research Institute has done a lot of contributions. As I mentioned, with SCP support, was identified as a national HIV reference lab in 1987. It has been performing testing to come up with algorithm, evaluation of tests, involving national sero surveys, molecular epidemiology, virus isolation and characterization, has been part of UVRI studies. It has a national sample repository, done a lot of work in HIV drug resistance, and several intervention studies with collaborating partners, especially the RACI project, the MRC unit, as you have heard, UVRI, and many others. The introduction of ART made a huge difference. And now I'll give you a brief on the history of ART access in Uganda. This one slide summarizes ART first given to patients here through those who could afford in the 1990s at the Joint Clinical Research Center, very expensive at that time, but those who could afford initially one drug, and some of the drugs that we are not hearing of today. It made some difference, not much, because at that time again, it was very expensive, very few could afford, until the AIDS Drug Access Initiative in 1999, when more people were accessed antiretrovirus. And slowly, more drugs became available, but the major change was in 2000 when generic drugs became available. And we have to be grateful to people like Peter Mujenyi, who made a lot of advocacy to ensure that we get generic drugs and ARVs become accessible to the people who need them. Of course, differences were made when the Global Fund came on, IDI, and of course, PEPFAR, that has delivered ARTs to most of our patients in Uganda. There are many others who have contributed, the Makere Joint AIDS Program, the Baylor College for Children, and many others who have really contributed in the delivery of ARVs. Where are we now with the 95? This is quite an old slide, a bit old slide, using UVRI data that is supported by PEPFAR. I think I try to get the most recent. I'm told analysis is not yet complete. Mary, prior analysis, we need more recent data from UVRI to know, and from AIDS Control Program. Wilford is here to tell us where we are with the 95, but I'm aware that the first 95 is the big challenge for people who are HIV infected to know their HIV status. That is where the biggest problem is. Otherwise, those who get to know their HIV status, as you can see in men, in women and men, and in totality, we have reached the 95. You can, many of these can access. And also those who are on ART, I think we're about to reach the 95 in terms of virus suppression. But there's a lot that needs to be done, to ensure that those who are HIV infected are known. I got this slide from SCP Wolford to tell us, it tells us where we are with people living with HIV as by December 2023. As you can see, we still see some rise. That is expected. Mortality is down, a few people get infected, but I'm told HIV burden is still increasing because HIV epidemic control is not yet attained in Uganda. It's not yet attained, but the rate of growth has slowed down as we approach epidemic control. You can see this in adults, in young people, the HIV is still with us. So there's some rise, and we have not attained, I think, the rates that will lead us to the control of HIV. This slide again mentions the new infections that we are seeing. They are reducing, but drop is slower. The rate is lower than anticipated under the UN political declaration. So we need to bend the curve more if we are to meet 90% drop between 2010 and 2030. There is a lot going on along injectable and HIV cure, and you hear more about this from Dr. Sally, but also there's some work led by Dr. Damali at Makerere University that's looking at HIV cure in non-subtype P, especially understanding the HIV reservoir during the long-term ALT. And as I say later, HIV cure is where we need to go if we are completely eliminate HIV cure and the vaccine. We have some work within the MRC that is looking at HIV cure with some young scientists who are beginning to look at HIV reservoir that will lead us to understand how the virus, latent virus. We have new challenges. The new challenges are known with everyone. The US stop order from President Trump, that is already beginning to affect. We are assured that care and treatment will continue, but I'm told by Mary that prevention is still in brackets. We don't know whether ART for prevention, but a lot of discussion continuing. Many of us, our groups have been affected with the termination of our funding from USAID, but we hope that we'll be able to overcome that. A lot needs to be done. In my last presentation, I want to tell you a little bit of what MRC has done as a contribution to the HIV control in Uganda. MRC, when started, the main reason for research was to improve the control of HIV epidemic through prevention and care both in Uganda and elsewhere. This was mostly based on the very well set up cohorts that were set up in the rural population in Chamliwa, and other cohorts in Masaka for HIV prevention, but also later in the key populations, the fishing communities and sex workers. And MRC has been able to provide a lot of good information on epidemiology in the general population, mostly looking at annual surveys, house mapping, census, sero surveys, and medical surveys. This work expanded from 15 communities to over 25 communities by the year 2000. This slide shows you a lot of work that has been described to look at the incidence and prevalence of HIV in these populations, information that has been very useful nationally and to WHO. I got this slide from Ivan showing the trend of HIV incidence over the years. Very happy to say that HIV incidence has been coming down over the years from, as you can see, in men, about 1% per 100 person years, but the incidence is coming down. You can see in the gray area where ART came in. When ART came in, we see a more drop in HIV transmissions, showing that ART is also effective in really reducing the HIV incidence. So I think this gives us some hope. There's a lot that has been done in social sciences. I don't want you to read these papers. Janet gave me these papers to show you how much social science has been done. Social science has been part and parcel of our work, A lot of work has been done to understand the HIV epidemic in families, in communities, bereavement, before ARTs, and even during the ART period. And a lot of information from social science has contributed to understand the epidemic and to control the epidemic, how people feel, gender issues, how people feel about ART, and all those important social issues that we require to control the epidemic. This is an old slide where the MRC was very influential in describing the progression of HIV. This was a time before ART, when one of the studies indicated that the progression from the survivor from seroconversion was a few years. As you can see in that graph, of course, it varied between age groups, but indeed before ART, people did succumb to HIV within a short period. And it was shown in this paper this was shorter than in the north. We have done a lot of molecular epidemiology, and I refer you to a presentation either I think today or tomorrow that is going to talk about the molecular epidemiology of HIV to show you how we have moved to pure subtypes A and D to now mostly unique recombinant viruses, complicating intervention because most of the viruses now we sequence are recombinant viruses. We even did some work to show that people get super infected and recombination occurs in these individuals. We also showed that the differences in HIV transmission by subtype, and this was confirmed by all the studies, especially HIV subtype D, that makes people progress faster. And one of the studies up to now that has tried to explain this was by us to indicate that HIV subtype D appears to use the XCR4 much earlier than other subtypes. And you know those viruses that use CXCR4 are more cytopathic, and they replicate very, very fast. And there is a post again, a presentation by my colleague, Annie Kapata, who is going to tell you the more recent information on transmitted viruses and the use of the co-receptors. We have done a lot of work looking at cellular and humoral immune responses, important for vaccine and to understand protection. We showed cross-clade protection, immune responses, but also it indicated to us that diversity will be a very, very important issue in HIV vaccine development. We have characterized HIV-transmitted viruses, and my colleague, Annie Kapata, will present to you how these viruses differ, the characteristics, their co-receptor usage, and their sensitivity to co-receptor inhibitor drugs. We have done a lot of work earlier on and more recently, and I'm happy to say that Sheena is one of those who has been part of us doing a lot of these intervention studies. Earlier on, very disappointing with Jane Kengea when they did STD treatment, did not show protection. But at least we have a Pro 2000 MDP program that really indicated that this Pro 2000 gel was not, and I followed the story of Pro 2000 from the lab when I was at Imperial College with Jonathan Weber. Phase 1, phase 2, exciting. Phase 3, disappointing. Very disappointing. Of course, we got some good results from the Paving more recently, and more recently we have done work using Descovy and Truvada. This is more recent work where we have shown that those individuals who use these oral drugs, the HIV infection rates are much lower pre their use and after their use. There's a lot of work that has been done even before ART to look at HIV care interventions, and this work is still of relevance. For instance, cryptococcal prophylaxis using fluconazole, which we showed was very beneficial, and the use of Septrin in HIV-infected individuals. I cannot forget to mention that, a very large study Paula was involved in and many others in the room that really showed we did the first and the largest ARV study in Africa to see how we can give antiretrovirals. At that time, we were talking about how we use lab monitoring, clinical monitoring, but this graph shows you at the top that lab or clinical monitoring did not make much difference. You could deliver ART using very simplified lab monitoring. But the graph, the line below shows the comparison of survival before the effect of ART, before introduction of ART, and after. You can see that years from treatment, from infection to death was very, very much reduced during the time before ART, but ARTs did show improvement in survival. We were part of a large study start that led to the test and treatment. That when you give treatment early, that is a START trial. We did another study called Spartak. I think, Sheena, you are part of that. At that time, there was a belief that when you get a very, very high viral load during the early HIV phase, you damage your immune responses and you progress very, very fast. So we said, if you treat short-term treatment very early in infection, maybe you'll slow disease progression. It was disappointing. I think we started a little bit late. You needed to do it very, very early. That was the time, it was ethical at that time because ARVs were given those who had reduced CD4 to 350. So you could treat for a short time in very early HIV infection. We have done a lot of work in HIV drug resistance, and I've shown one slide here which was used to change HIV treatment guidelines. This slide shows you pre-treatment HIV resistance to non-nucleosides. And we show that Uganda was one of the countries, as you can see, that has reached the level of 15% resistance among those individuals before even treatment, and a few other countries. And that led to the change of treatment guidelines to the use of the dolutegravir. My colleague, Ivan Namakola, will be presenting to you the work we have done on HIV and NCD, especially the integration of care that is now part of policy. And of course, we have done a lot of work on mental health and HIV, and you'll hear more about this. We have done a lot on HIV vaccine studies, including participation in the first HIV vaccine trial in adults and in children, and many other phase 1 trials. As I finalize, I've here listed some of the more recent HIV findings from our group, the benefit of the Paving ring, the high levels of pretreatment, as I've mentioned to you, the high HIV incidence, the fishing communities, characterization of HIV-transmitted virus, and you'll hear more about this, transmission networks that have allowed us to see how HIV is transmitted from urban to fishing communities, the benefits of test and treat, the integration of management of HIV and other diseases, and PrEP vaccine trial, the largest HIV vaccine trial in the region. I cannot forget capacity building that has come as a result of HIV work we have done over the years, training many scientists. You have heard Paula here, now in AIDS, and many others in leading scientists, policymakers, and we have trained many global leaders. Investment in platforms and data management has been very key over the years, and we are very grateful to our funders. The future. Here I've put some of the priorities for the future, for the unit. How do we contribute to reaching the 95-95-95 with the goal of ending AIDS as a public health threat by 2030? There are obstacles, as Paul has mentioned. How effective is the delivery of injectable for treatment and for PrEP? Strategies to reduce HIV in key populations and adolescent girls, HIV and comorbidities that will increase with people living longer, HIV cure research, characterizing our viruses, vaccine design beyond the germline targeting. In conclusion, I think the quick government response contributed to the control of the HIV epidemic through different prevention programs and international collaborations. The research collaborations have led to important discoveries that have contributed to the national and global policies and new knowledge. The introduction of ARVs clearly led to improved survival, and the future direction should aim at meeting the goal of ending AIDS as a public health threat. There are many funders, there are many collaborators. I could not list all of them. Time up as I do acknowledgement. Very, very good. I thank all of them, and thank you.
So I don't think I can allow Pontiano questions. But Eugene, where is Eugene? Eugene, I'm also wondering, I think if our last speaker, Julius, may not be able to attend, so we may have a possibility to have a panel from the speakers and still be on time for lunch. Is that okay? We'll see if that's possible. But now, if we could move on, I'd like to introduce, where is she, Professor Elizabeth Bakusi, who is a senior researcher at Cambridge. There she is. And professor at multiple universities. She has also a degree in bioethics, and she has been involved in many of the HIV prevention trials. So she is going to come and talk to us today about pioneering HIV prevention research, advancing solutions for Africa. Elizabeth, the floor is yours.
I hope it's still morning. Good morning. Oh, that was so lukewarm. Good morning. Oh, thank you very much. Now, let me tell you a story while I'm waiting for my right slides to be loaded. And I know that I won't get the same leeway like Pontiano did, because I know Sheena will cut me off exactly if I don't go beyond. But someone this morning said to me, "Oh, I'm really surprised that you are willing to come." And I said, well, when Pontiano asks me, I don't have an option. That's, arm twisting. When you get power at that level asking you, will you show up? Then you show up. So thank you very much. The second thing I was going to say is, the part of the country that I come from in Kenya originally could have been part of Ugandan. So I just might have been Ugandan. Had the border shifted a little bit, then I would definitely have been Ugandan. So I feel like a little bit that I really am home to some extent. But as my slides come up, okay, I've been told 1 minute. For me, HIV has actually shaped the trajectory of my career. Let me tell you a little bit of a story. My first encounter with sexually transmitted infections, I was a 4th-year medical student. And that's when we're also hearing about HIV. Now, we used to go to a clinic, and in this particular clinic, it was called the Dermatology and Venereal Diseases Clinic. Terrible words that we used in those days. And in this clinic, people would come in and get treated. So as a 4th-year medical student, we went to this clinic. It was somewhere in downtown, in a very dodgy part of Nairobi. People would come in and get treated. So one of the students standing in a corner waiting for this doctor who was treating individuals. And guess who walks into the doctor's clinic? A man with a collar. You know what a collar means? This is someone who's clerical. So he walks into the clinic and the doctor looks at him, takes one look at him and says, "Unbuckle your belt and drop down your trousers." And the man says, but, and he's told, "Quickly, unbuckle, drop down." And so he hesitates, and the doctor says, "Well, if you don't want to, you can leave. We won't treat you." And so the poor clerical man just unbuckles his trousers sheepishly, drops down his trousers, and we're all these medical students standing. We're supposed to be learning. Drops down his underwear and stands this sheepishly. And then the doctor looks at him and says, "But there's nothing." And he says, "Yeah, it's between my toes that I have a problem." It taught me a lot about how to treat patients with dignity and respect. But as a young medical officer, I also went to work at the border of Kenya and Uganda. And at that time, the epidemic of HIV was really starting to grow. And in the couple of years that I worked in the Busia, Kenya, not Busia, Uganda, we would often get young children who would come in with malaria. It's a malaria zone. And they would be so anemic. And who do you ask for blood? You ask for the parent to donate blood. At that point in time, we didn't have rapid tests. We bled people, then we tested, and then we decided whether to transfuse. And in the couple of years I was there, I saw us discarding from 1 out of 10 units to to 5 out of 10 units. And that's what made me think this is a problem that I have to be part of doing something about. Fast forward, I came to the point where I was now working as a young medical researcher. And I went back to the same shady part of town, STC, where we used to have the sexually transmitted disease clinic, because that's where we were working in order to do work in sexually transmitted infections and HIV. And I had the opportunity of being part of a research team. And so I had this gentleman who came in and were asking, we used to ask people terrible questions, we still do. You know, when did you last have sex? Who did you have sex with? How many partners do you have? Did you use condoms? You know, all these difficult questions researchers ask people. I guess they never ask themselves. They asked, okay, now the wife that you're faithful to, when did you last have, you know, sex with her? And he tells us, oh, you know, such and such a day. And so we asked, okay, have you had sex with anybody else? He says, oh yes, I had sex with my girlfriend. And then we said, but you said you were faithful to your wife. He said, yes, I'm very faithful to my wife and I'm very faithful to my girlfriend. I think my slides are finally on. Please allow me to take a minute to just recognize on Sunday, that was just this week, we lost Professor King Holmes from the University of Washington. Professor King Holmes was my mentor. He helped introduce me into the field of HIV. I learned so much from him. In the last few years, Professor Holmes has been declining. By the time this picture was taken, when I was with him, he had actually lost quite a bit of his memory. So he was very happy to see me. He was very excited to talk to me. But at that point in time, he didn't know who I was. He knew me, but he couldn't actually say my name. I want to recognize him as a person who made a big difference in the field of STIs and HIV. He helped change the use of terms like venereal diseases to talking about sexually transmitted infections. So it's a passing of a great icon, but his legacy lives on in people like me whom he trained and mentored, and in the many that I have had the opportunity to train and mentor as well. Does this work, or do I have to advance it here? Okay, I'll advance it here. In the next few minutes that I have, and I know they were timing me even from the time my technical problems were happening, so it's okay. I want to talk a little bit about the background, what kind of opportunities we've had for being involved in groundbreaking research, some barriers that we've been able to see, different models that we are talking about, and then I will conclude. I think Paula did such a wonderful job that I don't want to go back to talking about what the epidemic looks like now. But the concern I want to emphasize is that remember that the new infections are still being seen in sub-Saharan Africa. This is still our problem. This is still our challenge. And even in the wake of any edicts from any presidents in any part of the world, the reality is it is our problem, and we need to be able to find solutions for it. In Eastern and Southern Africa, that's where the heart of the epidemic still lies. I am unapologetically an obstetrician gynecologist by choice, and women remain the focus of my interest. Young women in particular have been a challenge for me. And I'm sad in a sense that once I was a young woman when this epidemic started, now I no longer am, as I'm reminded by the gray on my hair and the fact that I have 9 grandchildren. That reminds me I'm no longer that young. But HIV still remains a challenge. And it's a problem for me that my grandchildren, my granddaughters in particular, may face the same challenge that I faced very many years ago. So what kind of groundbreaking research have we had? I've met some colleagues in the room earlier on, and I'm so glad that we were part of what changed this trajectory around pre-exposure prophylaxis for HIV. When this work was done many years ago, Partners PrEP were able to show that indeed a pill a day does prevent HIV. And it provided an opportunity for people to start thinking about what other innovations can be done beyond a pill a day, which remains a challenge we are still working on even today. This has been, as you know, taken up by many countries, and Kenya and Uganda have been part of the teams that have been in the forefront of ensuring that there was uptake of PrEP in their countries. Again, this was a work that was done in Kenya and Uganda, the HIV Test and Treat search trial. Professor Moses Kamya, I'm not sure whether he's here, is part of this groundbreaking work that has been able to show test and treat is the way to go. When we look back, it's even amazing that at one point in time, we made economic decisions around when to start people on treatment. Nobody ever tells someone with hypertension, please go away. When you come back with a stroke, we'll start to treat you. Or tell a diabetic, when you're semi-comatose, we'll try and figure out what kind of medication we need to give you. But we did that for HIV for a long time, much to our shame, and thankfully, we have learned and are doing better. But one of the things we cannot forget when we're talking about issues of HIV prevention is the question around sexually transmitted infections. Because even in the wake of ensuring people are accessing and taking pre-exposure prophylaxis, we have seen a rise, particularly in bacterial sexually transmitted infections. And the concern among women in particular is because of the sequelae and what happens when women have infections that are silent, that are bacterial, that can lead to infertility, to premature delivery, to many, many years of challenges with their reproductive health, and we cannot pick them up or do something about it. We've been able to look at whether doxyprep is a way to be able to prevent women from getting recurrent bacterial sexually transmitted infections. Unfortunately, we're not able to show a difference, largely because, guess what? The women never took the medications. So we're still thinking this may work, and we're working to better understand the barriers and facilitators that may make it possible for women to use pre-exposure prophylaxis for sexually transmitted infections, because this, remember, also predisposes them to HIV. So what are some of these barriers that we've been able to identify? Now, the model of PrEP delivery has largely been you initiate and then you continue refills within a healthcare facility. But guess what? There is a lot of stigma, and stigma still kills more people than even the infections itself. People struggle with distance and time. Waiting times in clinic have always been a challenge, and especially young people who are basically well do not want to go to a healthcare facility. And then the hours that we open are very unfriendly. They're convenient to us as healthcare workers. They're not necessarily convenient to people who are working or who are involved in other trade activities. Male partner involvement remains a very important thing. I did say my focus has been on young women and really thinking about how we can protect and prevent infections among young women as a way of breaking this cycle so that we don't have generations who still have to struggle with issues of HIV. But ensuring that we are able to get their partners on board, making sure that we are able to provide opportunity where the norms change and that prevention is an opportunity for everybody to get engaged has been very important. This was mentioned even by Dr. Pontiano and also earlier on, that the questions around women, lactating, pregnancy remain a challenge. And we know that pregnancy is a particular time of risk, and especially also in the lactation period. Finances remain a concern, and even now, Pontiano was talking about the issues of finance, big issues around what does it actually cost? Can our governments, can our own funding sources be made available to be able to protect people? And the big concern right now is indeed, even if we continue treating and we do not prevent, it remains that concern that we will not be able to end this epidemic. The countries that are most engaged and most involved and have the largest epidemics do need to make decisions about how they are going to fund and what they're going to do in order to manage this pandemic. So what are some of the solutions that we have thought of creatively and that we have been working on with many other individuals, including people who are here? So one of the things that we are doing as a work in progress is what we are calling a one-stop shop. Because often what happens is you come in, you get tested in one place, you get referred to another, you are counseling at a different place, and you pick your medication from a totally different source. This means one line after another. People often get fatigued and simply leave. Can we create a model in which in one particular stop, an individual can get tested, can get counseled, can be initiated, and actually take their drug? They simply walk away from clinic having completely finished all that they're doing. So this is a work in progress. Stay tuned, results to come soon. We also looked at what are community ways of being able to deliver medication using peer-based, similar-aged individuals. I've been quite surprised to discover that I no longer fit into the peers of young women. They look at my gray hair and they really wonder why I'm even talking about issues of sex and PrEP. But people who are their own age, they're very responsive to, very willing to have delivery of medication, delivery of self-testing, and then looking at ways where we can really decongest our healthcare facilities and allow community-based models to continue to provide this. We completed our pilot test, and we were not only providing just pre-exposure prophylaxis, but also providing opportunities for contraception. Just in case you might have forgotten, the same route in which people get HIV for young women is the same route in which they often get pregnant. So they need to have dual prevention. And this has been work that has been going even in the multi-purpose prevention technology era. Can we find ways that provide double solutions, kill two birds with one stone, so to speak? But in the absence of that, can you find a model where you have more than one product that's provided for individuals who need it? So we are still looking at this, and we are trying to find out, can we find more ways of being able to expand this? Can we find a cost-effective way of delivering PrEP and other services to young women who need it within the community using peer models, and then ensure they not only stay safe, but they're also to provide for all their reproductive health needs. We then thought about, where do people get services? Now, I'm sure Uganda is a lot like Kenya, and we have very many pharmacies. And often, these pharmacies are the first place that people go to, because going to a healthcare facility takes a bit more time, registering in queues and so on, and pharmacies have easy access to individuals. So we initially did a pilot of trying to see, can we deliver PrEP through pharmacies? Many of these pharmacists, because they're commercial outlets, the challenge is, do they have the time? Do they have the privacy? Do they have the willingness to be able to do this kind of work? Now, we found out that this is indeed something that functions very well. In addition, they work over the weekends when many health facilities sort of go into a slower mode and only deal with emergencies. So right now, we're actually in the process of ensuring that we're actually working on a pilot delivery, a substantive study that's looking at delivery. We have what's called remote clinician support, because in many of our countries, PrEP remains a drug that is prescribable, and the pharmacists will dispense rather than prescribe. So there does need to be clinician oversight in order to be able to provide the PrEP. And we are in the process of trying to see what models work. Is it that people want to be initiated and then followed up within a healthcare facility? Do they want to stay within the pharmacy? Do they want to pay some amount to the pharmacists? Because pharmacists do charge some kind of a fee. And what would work in terms of a sustainable model of being able to provide pre-exposure prophylaxis, initiation, and continuation within a pharmacy setup? So our takeaway is that pharmacies are places where PrEP can be provided. Clients are very willing and very enthusiastic, and they actually have very good continuation rates. There's very high acceptance among both the clients and the providers, and many people are actually willing to pay some fee in order to be able to get these services. I want to point out that the people who tend to go to pharmacies are younger, they are unmarried, and interestingly, they have partners whose HIV status is not known, meaning these are the very individuals we need to target if we are thinking about reducing new HIV infections. So, high acceptability, as indicated in these quotes, they like it. It's accessible, it's instant. It's close to where they live, and there is privacy. It's much easier to get than if they go to an hospital. And because they find that the clients find they're open with the pharmacist, they're already getting other products from them, that this makes it an easier way to be able to get PrEP. So as I conclude, before Sheena raises her flag and tells me my time is over, it's been a pleasure and a privilege to be part of the journey of pre-exposure prophylaxis and thinking of different models and different opportunities for ensuring that individuals who want to make choices not to get infected can have that opportunity. Especially among the young women who, for me, have been a target, because it's an important cycle we need to break. But recognizing, especially in this day and age where we are struggling with limited finances and access, that we do need to think about what are the innovative ways that would allow us to be able to provide such services, expanding it into opportunities for other reproductive healthcare models to ensure we can have a generation of women and individuals who will be HIV-free. Thank you very much for your attention.
Absolutely marvelous. I think Eugene, where's Eugene again? Because the questions, it's a very large audience. I was saying we've got a roving mic, but it's quite difficult, I think, to do the questions in this way. So is that all right, Elizabeth? Thank you so much. It was a really fantastic talk. And I loved your story at the beginning. And I didn't know King Holmes had died. He was an absolute icon. I also trained in venereology as well, and my introduction to HIV. But it reminded me of when the Bishop of Exeter came and sat in the Exeter clinic at the end of the row, and we really weren't sure what to do. And Betty, who was one of the nurses, went down and said, oh, just ask him what he was there for, which was very brave of her, but he was there to have a blood test, so we sent him round to the right clinic. Okay, so now it's my great pleasure to introduce Dr. Francis Saleh. Where are you? Oh, brilliant, welcome. He's the Deputy Executive Director of JCRC and an expert in HIV treatment, internal medicine and hematology. He's been working in clinical trials for 30 years, and he's extremely well placed to tell us about the pioneering HIV treatment. And the last bit, again, advancing solutions for Africa. So Dr. Saleh, thank you.
Thank you. Good morning, everyone. Thank you for the opportunity to attend this meeting and to lead this talk. Or maybe I use this.
Yes, so Elizabeth used the computer, but it's not up now,
Okay,
so we just wait.
They changed it a little bit.
Yeah.
Yes. Yes, I'll bring with me my experience from the Joint Clinical Research Center, where I've been for quite some time, and also in clinical practice. So I think all of us do recall the story of HIV in Uganda. I think it's good Dr. Kware is here. Everyone who has been in Uganda knows about this first paper on Slim disease in Rakai in 1985, and how there was no treatment after that. I think you can see a big hole dug up there by Nanyonga, and people had eaten away a lot of that soil for treatment. And the ignorance was not just here, but even in the US, you can see policemen who are trying to arrest some activists in the 80s. They all have gloved fingers so that they don't have, and gloved hands so that they don't catch HIV. And this is what HIV looked like in the late 80s, throughout the 90s, and even the early 2000s. This was a child who was at the JCRC, but most patients used to present like that, the typical slim disease, as Dr. Kware used to call it. And we all know, most of us know about Phile Lutaya, who was one of the activists that, one of the first people to declare that he was HIV positive in Uganda. And Philly later on died in 1989, but he had had some therapy with monotherapy with the AZT And on your right, you can see the two curves, curve A with people who had AZT monotherapy, and B, those who didn't have. You can see the AIDS-free survival the curves are not very, very different. They're only slightly different. And even the overall survival, and that's what was available. And the doses were given in the range of 600 to 1,500 milligrams of zidovudine. So those are a lot of toxicity. One of the studies that looked at dose of HIV was done at the JCRC. And if you look at the early guidelines from the experts in 1993, you can see they were recommending this as a T treatment if someone had, you can, we've gone through so many guidelines, and even the WHO, many of you recall the first guideline in 2002 when we used to wait for CD4s to drop below 200 before we could start patients on therapy, and then incrementally we went to 350 to 500 until we reached the point of not deferring. And on your right hand, you can see these three curves, one of AZT monotherapy, one of DDI monotherapy, and one of combination of AZT and DDI. And actually there was this one of the first papers that showed that combination therapy was beneficial. And later on, those of you who are around in 1995, remember the Vancouver conference, which the PIs came out first time, and triple combination showed that patients can get their immune system to recover. And actually at the end of that conference, people thought there was a cure for HIV. But as we moved down the road, resistance emerged. And although a number of PIs had come up at that time, it was found that actually these drugs, much as they were good, bioavailability was quite low. They needed to be taken with food, and that time boosting was not done. So we used to treat some of the patients without any boosting with PIs, and many of these patients got resistance. Going forward, 2003, when President Bush visited here, and he sort of later on opened up the PEPFAR program, we started treating patients with didanosine-based combination because it was effective, easy to start, didn't have any initial trouble when patients started it, and we also thought this was the savior of mankind. And until we got into mitochondrial toxicities. And then, there was some questions now arose. That time we didn't have efavirenz, we didn't have tenofovir. Those two molecules came a little bit later in the general pool. I think because we didn't have generic efavirenz and generic tenofovir, they came a little bit later. So there were studies now to see, can we interrupt this potentially beneficial therapy, but also toxic. And there were so many studies, but this was concluded in the SMART study, which showed that actually interrupting therapy did increase the risk of death. It increased the risk of of HIV-related events, and also the patient's immune system didn't recover that well. So that was a landmark study. And when that was resolved, the next question is when to start therapy. And this was eventually concluded in the START study, which looked at deferring therapy for patients who have CD4s of below 500 or starting at 500 or starting everybody at that. And the summary of these curves, I'm sorry this slide is busy, but you can see that the individuals who did not defer any therapy, they suppress the virus quite early, and compared to those who deferred therapy, and also they maintained their immune system. They had fewer deaths overall, and they had fewer AIDS-related events. And there was an excess of some cancers in those patients who deferred therapy. And this opened up that solved the question of when to start. And from then on, it was guidelines, WHO and other country guidelines to now adopt to start everybody on therapy, regardless of CD4 counts. Actually, that study now diluted the value of CD4 counts and reduced it to just being able to predict what sort of morbidity a patient might have. And then the next question was what to start with. Okay, we know we should start everybody, and I think that time we had got efavirenz, but the new molecules, the integrase strand transfer inhibitors came on board. DTG came along, and for quite long, efavirenz was the gold standard, and the START study. This study actually showed that DTG was non-inferior to an efavirenz-based combination. The two key studies, one of them was based in South Africa. And so after this it opened up now. We had another molecule that we could use, we could combine with the nucleoside analogs. On one side, it was abacavir and tenofovir. We didn't at that time have much trouble with either, although later on we found that abacavir in older patients had an increase in the risk of myocardial events. And since then, now abacavir is used in young people only. It's largely pediatric domain and young adults. And I think this study alone could not make us to shift from efavirenz. There were cost issues, from efavirenz to DTG, but we had bigger trouble because we had used the non-nukes for quite some time, and resistance was brewing in our community. We were fast adopters of single-dose nevirapine for maternal prevention of mother to child. So eventually, we had a lot of resistance to NNRTIs, and that was the main reason why in Uganda we shifted to using DTG. And besides, over time, we've seen that it's relatively durable. So now that we had used DTG, we had used the nukes, we had used the non-nukes, we had used the PIs, everything was in the mix. What happens if somebody failed therapy? What would you do? And given, again, our current guideline is now if someone has failed, regardless of whatever regimen they're on, we do a resistance test, because everybody is used, there's no drug which is line specific. We use the same molecules in first line, in second line, and third line, maybe with the exception of the PIs. Now moving on, there are some new molecules that have been tried. As people stay on therapy for a long time, they're worried about being on treatment for a lifetime. So we've had to look at long-acting antiretroviral treatment, and one of the trials that was done at our center looked at the use of injectable lenacapavir together with, this is a different one. This is an oral study. It wasn't done at our center, but it is a very promising approach to treatment, because I know we've been talking about injectable antiretroviral treatment, maybe giving people treatment, an injection once every 2 months, or perhaps moving to once every 3 months. But this is staying within the oral domain, but giving someone once a week therapy. So this is a potentially promising study, where we will have islatravir and lenacapavir. The only challenge with islatravir can actually even be given once in every 6 months, but it has a big drawback in the sense that it pulls down the T cells, the lymphocyte counts drop, the CD4 counts drop. And I think that's what made the manufacturer to pull back. But the oral dose of islatravir appear to be quite all right, the once a weekly one. And you can see that if you compare that with standard of care, you actually get very, very good suppression. So maybe as we move forward in the epidemic, this is one of those options that we might have to think. It doesn't require any injection, doesn't lay any extra burdens to the healthcare system, and patients can get this anywhere, even if they are to go to a pharmacy and pick their once a week pill. The long-acting injectable cabotegravir, Paving, this was the study that it's been ongoing at our center, and actually in this CROI now there is a week 96 data being presented in this CROI. And the study compared the injection with 2 drugs with standard of care, and you can see that at week 48 there was equivalence actually. First of all, the virologic suppression was very high and above 95%. There are other approaches that have been used to look at oral lenacapavir, and this was not a Uganda study, but it's also quite promising in the sense that this drug can be active in patients who are heavily treatment experienced. And you can see that you can achieve suppression in over 75% of patients. There are some new, sorry, I don't know how to remove the it's gone. Yeah, it's good. There are some new approaches to treatment currently reserved for individuals who are failing the existing option, and the broadly neutralizing antibodies are being tried, a number of them, and they essentially work in 3 ways. One is neutralization of the virus, the other one is complement-mediated toxicity, clearance of the infected cells, and it can be through CD8, cytotoxic T cells, or using NK cells. And even some macrophages can also, it can also work through there. There are key challenges with the broadly neutralizing antibodies. They don't have durability, and sometimes the cells they are targeting do not have, they have quite low density of the viral epitopes that they are targeting, and also the virus keeps changing, and in some cases the immune system is just exhausted, and they have a relatively short half-life. So I think the next studies are just going to look at how these molecules can be extended, combining BNAbs. The other one is actually engineering them to make, to conjugate 2 of them and make it bispecific, where you get 2 different antibodies and conjugate them to make one product, which is not necessarily more potent, but broader in the terms of viral isolates it can address. I know, looking at what has happened in the last couple of weeks or months, we don't think PEPFAR is going to be here for good. That's a given. And so are we going to treat patients forever? So we also need to think about how to cure our patients. I know we've not had any success, but I think this is something that is achievable in our lifetime. Because so far, there are 7 individuals who have been cured of HIV, completely cured. The only issue is that actually they had another adversity. They had a cancer that came in. Some of them had acute myeloid leukemia, others had a very difficult lymphoma, and they required a bone marrow transplant. All of them, except one, have been men, but the last one, I think, was in New York, a woman of mixed race, and she's actually the only woman among the 7. So the approaches to cure of HIV, I know the vaccines we are still waiting for them. I hope Pontiano will get us one. But in the interim, we are thinking about gene therapy, and we are looking at initiatives to get into gene therapy trials, because there are quite a couple of them that have been successful for other diseases. There are some products that are currently in trial for HIV, and of course the others are these transplants, mostly allogenic. I think this case here was published last year, about this time, in an elderly man, a 63-year-old man. Most of the other patients that were treated were young people, but, oh, sorry, I've lost the screen. How can I open up the screen? So this patient was a 63-year-old man, not that one, a 63-year-old man, and he underwent a bone marrow transplant. Bone marrow transplantation is, you get slightly more chemotherapy than would normally give for a cancer, so that we can knock out the entire bone marrow, and so that we can then replace it with the graft. And so this patient had acute myeloid leukemia and was able to get treated for both. You can see down the blue dots are the viral loads. Patient was on DTG-based ART. He went through the conditioning for the bone marrow. You can see the CD4 cell counts dropped, and then after that they came up, even when he was on some immunosuppressant to prevent graft versus host. So this one is a slightly, this might be like 2, maybe 3 years now. Castello was a young man. He had a Hodgkin's lymphoma, which was very difficult to treat, did not respond to therapy. This is the London patient. So Castello had a bone marrow transplant from a donor who had a mutated CCR5, which was homozygous with a delta 32 mutation. And Castello had cure for both the Hodgkin's disease and for HIV. So he's walking around a free man, and I don't think he can catch HIV again, unless if it is maybe a CX, the X4 virus. Okay. So what is the principle about the cure using the transplantation? This is the New York woman. The New York woman, the transplant she had was slightly different. She had 2 grafts given at the same time. One was a cord stem cell graft, which had a mutated CCR5, and then she also had a bigger graft, which was somebody who was half matched. So the point was, in the cord graft, there are very few stem cells, so it will take forever, it will take months to engraft. So she was given this half-match graft from an adult donor, and over time, because it didn't have the it didn't have the CCR5. And over time, those cells went away, but they protected her. They gave her a good immune system. And then they exited after some time. And then the cord graft took. The cartoon down here shows the purple. That is the cord stem cells. And eventually, over time, that's what she has now, completely cured. So the other alternatives have been to get to get stem cells, work on them in the lab, induce the mutation, the delta 32 mutation, and then transfuse them back into the patient. One patient has had that, but I think there was low transduction efficiency, so the delta 32 stem cells were quite low in him. But even after interrupting antiretroviral treatment, over time, the patient managed to suppress. Now, you've heard about the CAR-T. So CAR-T cell is a different approach to trying to cure HIV. These are chimeric antigen receptor T cells. They are engineered in the lab to express receptors for the HIV envelope and also for the and they can then capture it or attach to it and then destroy the cells that harbor that virus. You can see the key issue has been that the initial constructs of these CAR-T cells were not very durable. Some of them could actually be infected by the HIV, and so there was loss of those cells. And the current approach now is to there have been several generations now of the CARs improvements, so that one of them is actually the one we're going to try at the JCRC within these 2 coming years is a dual CAR. So that improves it protects it from attack by the HIV. So there is still improvement, but we need a cure. Thank you very much.
I've just heard from Julian that our last speaker is here. But any quick questions for Francis? Thank you. It was really inspiring, telling us how Uganda was so much a part of those pioneering treatment trials that completely changed the face of treatment. But thank you also for reminding us what it was at the beginning and how far we've come, in a way. Thank you, Francis. Julius, are you here? You're here, I understand. Oh, welcome, welcome. So my pleasure to introduce Dr. Julius Lutwama. He's the Assistant Director at UVRI, expert in arboviruses, viral epidemiology, and the outbreak response with 40 years experience in research in Ebola, Marburg, Zika, and influenza. So thank you so much. You're here to tell us about the next wave, preparing for emerging and re-emerging viruses. Welcome.
Thank you. You're taking this one? Okay. Good afternoon to you all. I've been introduced, and thank you very much for for your introducing me so warmly. I'm going to speak about preparing for emerging and re-emerging disease threats. Of course, I know everybody knows about this, but I put this here to give me direction so that I don't go off my own line of thought. So emerging threats are new, unknown, or newly identified risks. These could be diseases, they could be cyber attacks, these days they are also threats, or they could be technological advances like AI. AI is an emerging threat, which have the potential to cause significant harm. and of course, re-emerging threats are previously known risks that have reappeared after a period of decline. Of course, they include infectious diseases and environmental threats. I'm going to limit myself to diseases as threats. Many of the emerging infectious diseases are zoonotic in origin, and it is believed that between 60 and 80% of these emerging infections are derived from animal sources. So that's why they're called zoonotic in origin. For an infectious agent to emerge, there are two main steps. An agent is introduced into a new host population, a naive population, and then the agent establishes itself in that population, and then there is sustained transmission within the new host population. There are very many diseases that have emerged. This is just to show you that there are very many. Between 2023 and, 2003 and 2022, so many have emerged, and only those are a few that have been captured there. And these are happening everywhere in the world. So you can see almost everywhere these diseases are happening. Coming a little bit closer, you see these are hotspots or emergent zones for zoonotic diseases. And of course, we can see that Uganda is one of the places which are actually hot zones, emergent zones for zoonotic diseases. Of course, in Africa, there is West Africa there and Ethiopia, but mostly in Southeastern Asia. However, I am interested in the area of Uganda. And several maps, of course, have come up, and all of them are indicating the same things. So you see that, again, Uganda is indicated there as one of the places where there are lots of diseases that are emerging. Even on this, on that map. The map up there, this one here, is showing where more diseases are reported. So it is not because here they are reporting more diseases. More diseases are reported there because of their own systems. But actually more emergent, these are the emergent zones where the diseases are coming from. Taking an example of viral hemorrhagic fevers, you can see how many of these have been taking place in Uganda. There's so many. I'm not going to start going through each one. But as you can see, so many have occurred since 2000. These are only viral hemorrhagic fevers, but there are also other diseases which are not listed here. I'm listing these because these are the ones I've been working on at UVRI. And of course, this one shows a chronology of how these have been happening. There are so many, and of course, so small, but again, this is to show that there are so many of these which have been emerging in Uganda. So what are the strategies for preparation? What do we need to do to prepare for these outbreaks? Of course, one of the important things is early detection and surveillance. We need to establish monitoring systems and early warning mechanisms. Here in Uganda, we have quite a number of early warning systems, surveillance programs. Even at UVRI, we have several of these being carried out. In my department, we have the viral hemorrhagic fever monitoring system. We do surveillance for viral hemorrhagic fevers, Ebola, Marburg, Crimean Congo hemorrhagic fever, Rift Valley fever, Sosuga, and several others. We do arboviruses. We know that in Uganda, we have more than 90 arboviruses which are circulating all the time. Of course, we are not surveying on all of them because we don't have the diagnostics for all of them, but at least for 24 of these, we have a system that we collect and try to identify which of these are occurring in different parts of the country. So we have to have a monitoring and early warning systems to be able to be prepared for whatever disease is going to come. We have to continue research and technological development, and of course, UVRI is one of the areas where we do a lot of research and development for any emerging disease. We have to put up public health infrastructure. We need to strengthen healthcare infrastructure to handle surge in patients' numbers when there is an outbreak. The Uganda system has been that all health center 3s and health center 4s have been uplifted, and many of these are being turned into hospitals. While this has been necessitated by the fragmentation of the districts, it is actually one of the policies that all of these are uplifted. At least the what happens at each of these facilities is increased, such that when there is an outbreak, then this can be, at least we are prepared for that. All district referral hospitals now have isolation facilities, such that if there is an outbreak, at least we don't have to move people from one place to another. So as a strategy for preparedness, we need to strengthen our healthcare infrastructure to be able to handle surges. Of course, training and education. There is ongoing training for healthcare workers, both those who have come out for training, but even those who are being trained formally. They are now being trained such that they may be prepared to handle outbreaks, to handle pandemics when they do occur. There's a lot of ongoing training and fellowships which are currently being carried on such that we improve training and education of the health care workers. We need to have a lot of community engagement. If the communities are not made aware, if the communities don't know about these diseases, then when anything happens, they may not know until so many people have died. Before, we used not to engage the communities, and we would only know about outbreaks when many people within the communities have passed on. These days, even before an outbreak, there is a lot of awareness being built. Public awareness is being built within the communities such that we know what is going on. And of course, a lot of vaccination is taking place. We need also to involve the communities such that they know what to do when there is an outbreak. They know what to do when they see anything strange. I have a program where we are doing One Health. And what we are doing in this program is we have gone to the lowest level and have put together healthcare guides, wildlife care guides, and health volunteers together, such that they are working together to be able to see whatever is happening to the communities, and they are reporting this to the parishes, and the parishes report this further on. This is a kind of community engagement that is allowing the communities themselves to take care of themselves, to see whatever new happening in their communities such that they report it. Even if they've seen a cat die or a dog die or anything that dies within the community, they report it, and then somebody comes to at least respond. That way, we should be able to get the first incidences of some of these diseases. Because for many of these diseases, we only come aware that they are happening after many people have died, or when we cannot really trace the very first incidents. If we can trace the first incident, then we may be able to tell where these diseases actually originate. Stockpiling and logistics is another strategy. We need to have emergency supplies. This is a very big problem in many of our African third world settings. We do not have emergency supplies. And when outbreaks take place, we have to start scrambling up and down to see where we are going to get the essential medical supplies and equipment to be able to mitigate the problem. Of course, we need to do a lot of logistic planning, developing efficient distribution systems, and having stores in different places to be able to quickly get what we need when there is an outbreak. Simulation and drills. We need to have preparedness plans. It is difficult to have so many different plans, but there are so many diseases that we actually need to have at least plans for, let's say if they're going to be viral hemorrhagic fever, then we have plans ready for viral hemorrhagic fever. If they're diarrheal diseases, we have plans for those. If they're parasitic diseases, we have plans for those. In some incidences, we have these plans, but we never do regular drills. The drills we normally hear about are fire drills. Everywhere you go, there are fire drills, but they never go into preparedness for diseases. But whatever institution you go to, they will tell you, oh yes, we have drills, we do drills, but they are fire drills. Of course, we need to develop scenario where we need to at least practice some of these things, practice response plans, to be able to have this inculcated into people, to know what they need to do when there is a scenario of an outbreak. Financial investment is another strategic preparation plan. We need funding, secure, adequate funding for preparedness initiatives and emergency response. This is another big problem. I have seen Dr. Okware here in the audience. The last time I heard that the Ministry of Health had an emergency fund was during his period, because that is when I used to run to his department to ask for some preparedness funds when there was an outbreak. Since then, I've not heard that there is a preparedness emergency fund in the ministry. Every time we hear, we call donors, there is an outbreak, please come, we need some assistance here and there. But we need to have funding ready, which is put apart for these emergencies. I know we have a problem in Uganda because at any one time, there is an emergency in Uganda. At any one time, there is an outbreak going on somewhere in the country. Insurance mechanism, we need insurance. Say that people with all of these kind of outbreaks, people need to have some kind of insurance. But even the government needs some insurance options. I'm coming back to this slide. What I want to portray here is that if you have established systems, then you can mitigate outbreaks as quickly as possible and reduce on the number of people who are being affected. I don't know. On this slide here, this is the first Ebola outbreak. And as you can see, there were so many people who were infected. There were so many people who were infected, and of course it took some time before we were able to diagnose what it is. Then during the second outbreak, of course, it took long, but this was quickly stopped because this was Ebola Zaire. Then there was Ebola Bundibujo. Of course, it took us very long to be able to identify what it was, but again, you see the number of people who were affected were very many. When we started the laboratory at UVRI, you see the number of people who were affected were reduced because we were quickly diagnosing what the problem was and quickly stopping the outbreak. So that is what is important about being prepared and building infrastructure and having everything in place to reduce outbreaks. So what have we learned out of the so many outbreaks that have occurred in Uganda? And I'm bringing this to show that all of those strategies, at least Uganda has tried to put some of those strategies in place. Of course, there is a lot of improved training and health care training of the healthcare staff. There is formal training in schools and training health facilities, but also out of the facilities, like I said. There is a lot of disease surveillance capacities with active disease surveillance programs in place, like I said, at UVRI, but also at the Ministry of Health. There is a national sample referral system such that any health facility within the country can refer their samples for diagnosis. And this has also assisted very much because whenever they see anything far off from the lab, at least they pick the samples and they send them either to UVRI or to CPHL where this can be diagnosed. Of course, laboratory diagnosis capacities, of course we have said UVRI, we have improved our capacities, but also other health facilities, they have improved the laboratories in those places. There is real-time electronic reporting because this is part of surveillance. You can't do surveillance and don't report what you have, but real-time electronic surveillance has increased the speed at which results are got, and then it increases the response that can be taken, can be done. Of course, the establishment of the National Emergency Operations Center was very critical because this allows coordination, and of course, together with the EOC, of course, there is a national task force for outbreak coordination. Coordination is very important because if you are not coordinated, then you cannot mitigate because everybody will be doing their own things and you wouldn't be able to stop the outbreak from going on. The multi-sectoral approach, I already talked about One Health. There are One Health teams, and of course, this is very much in policy, but actually does not really actually take place very much. But of course, this is what we would like to see, One Health teams going out in the field, One Health teams working together to be able to mitigate diseases. Our experience of outbreaks has at least reduced us from panicking. We don't panic very much when outbreaks occur. This allows us to be able to practice all that we need to practice without panicking. And of course, there's improved biosafety and biosecurity in health facilities, but also in the laboratories. There is health systems development, and of course, research. And of course, there has been a lot of political leadership involvement. This is also important if we are going to be able to be prepared and mitigate outbreaks. Of course, after having portrayed that, one would imagine there are no challenges or there are just a few challenges. But there are quite a number of challenges. One of these I've already talked about. We are living in a disease emergent zone. That is a challenge. It's a challenge we cannot stop. Dependence on aid. We are always depending on aid. Like I said, if there is an outbreak, you see the Ministry of Health always inviting people, inviting donors, inviting partners to come and see what can be done. Of course, we need diagnostic therapeutics and vaccines as well as personal protective equipment. All of these, normally we don't have them. So we rely on aid to get all of these. So we need to invest enough in health and disease control. When you look at our budget and see what goes to health, let alone what goes to surveillance, is very, very small. So we need to invest more in health and disease control. Of course, not investing in preparedness. While we're talking about preparedness, how much preparedness really goes on? How much preparedness do we do? I talked about drills, these are not there. Preparedness plans are not there. Lack of sustainable funding for research and development. Of course, we import up to 70% of our drugs, vaccines, and requirements. We do not have a biotechnology sector in this country. It is virtually non-existent. Yet, if we are to produce our own vaccines and therapeutics, we need to have a biotechnology sector. That will be able to at least put us on the way to get some of this. Of course, there is also severe shortage of human resources, let alone those who are there have poor pay. So what do we need to do? We need to invest in modern disease surveillance systems. We need to invest in laboratory capacity. We need to improve our health security workforce, and of course, do a lot of outbreak planning and readiness. We need to improve our capacity to mobilize resources to respond to outbreaks. Not only mobilize them, but also keep them somewhere ready for emergencies. We need to improve the supply chain for health systems. Not all the time getting this when an outbreak has occurred. We need to put this in place, ready. We need to have supplies kept and be used when in need. We need to invest more into vaccine and therapeutics manufacturing capabilities and innovations that we can respond timely to outbreaks and future pandemics. So, are we prepared? Not only we, the whole world. Is the world prepared? When is the next pandemic? We do not know. Where will the next pandemic begin? We hope somewhere in the emergent zone, probably not Uganda. What will be the nature of the next pandemic? We do not know. Does each country need to produce their own countermeasures? Probably not, but we need to work together. Do we have pandemic preparedness plans? We need to ask our sectors here. Do we exercise our plans? Not often. Thank you very much for your attention.
So I think we have, I know we're a little late, but I think Eugene's allowed a 10-minute lapse in the timetable. So we have a few minutes. And Francis, I have some questions from our online audience for you, if you wouldn't mind to come up. I'll read them because we'll have to share this microphone. So, are there any observed clinical complications with bone marrow transplants for the HIV treatment option? I think they look pretty good.
Yeah, thank you. Bone marrow transplant, the reason it's not done routinely for just purely HIVs because the procedure inherently has some risks. So there is chemotherapy that's given, that's the biggest risk, and then it's given to remove the patient's entire hematopoietic system, and before the graft actually takes, there is a period of vulnerability that the patient might be, can get fungal infections, can get bacterial infections. Even the chemotherapy itself has some side effects like, mucositis. I think those are the key things. And then later on, there can be some graft versus host reaction. But the HIV per se is not a bigger risk for transplantation. We've seen that even for patients who have kidney transplants, they just do fine, just like everybody else.
No, yeah. That's the great thing, isn't it? It doesn't add to the risk. And then, and I've got, okay. Just some more questions. So, why did we have high mortality with AZT? Maybe one more first on the bone marrow. Does Uganda have the capacity to carry out bone marrow transplants?
Yes.
Yes. Excellent.
Yes. Working on it.
Yeah, wonderful. And the high mortality with AZT alone?
So I think the high mortality for AZT was largely because the patients got resistance subsequently. Mm-hmm. The durability of monotherapy was less than 6 months. So within 3 months of the therapy, patients started getting mutations. And yes, for that, thank you. And then also the dose was really high. At that time, someone getting 1,500 milligrams of Zidovudine because nobody knew what dose would.
Their hemoglobins went.
So patients had a lot of toxicity. Yes.
I mean, that is a time, isn't it? Even when we first had the PIs and the triple therapy, there were so many tablets people had to take, and the toxicities were unbearable. Yeah. Thank you so much. Thank you for answers. So a question, Julius, for you, please. How are you handling the biosafety and security for the infectious agents like Ebola and COVID?
Well, we have, let's begin with the Institute. At the Institute, we have a Biosafety and Biosecurity Committee. This oversees all the activities in the laboratories at UVRI. It oversees all the way from when the samples come to UVRI up to the time when the testing is done, and whatever remains is either kept safely in deep freezers or it is incinerated. In the country, of course, there is also a National Biosafety and Biosecurity Committee which oversees the handling of both patients who are sick with these diseases. When people get sick from these highly infectious diseases, of course, they are taken to isolation wards to make sure at least that there is containment of the people who are suffering from these diseases. And of course, all the samples are removed from there and taken to facilities where these can be safely handled within the country. I think that is how the biosafety and biosecurity for these diseases are handled within the country.
Thank you, Julius. And I have a question for Elizabeth from the floor. Paula.
Oh, you're making her walk up. Yeah, why not? Hi, Elizabeth. No, my question is, it's burning me. How do you feel about, first of all, thanks for the models of PrEP that you presented. I mean, that's really fascinating work and well done. How do you feel about a universal offer of PrEP for pregnant and breastfeeding women? You know, somebody sort of put that on the table somewhere and said, these are women, mostly young girls actually, who are self-declared high risk because they're pregnant. How do you feel about, I don't like the word universal, but yeah, universal offer of PrEP to prevent transmission?
So by saying universal, give everybody who's pregnant, offer everybody who's...
Offer it opt-out in high incidence settings, I might add, yeah.
Okay. That's a really tough question to answer. So how do I feel about it? Well, I think the question of choice is always one that's important. So in terms of offering it, yes, perhaps it may be a good opportunity to offer, but always to give the opportunity for people to make the choice. Because part of the challenge of choosing is, you take a pill, you're going home with it. Who is at home? Where are you keeping that pill? How are you going to be able to take it? How do you explain why you're taking it? And that's why options, for example, if you think about the contraceptive world, Depo has been very popular. Why? You go, you get your injection, nobody knows you went and got it. Nobody knows what you're doing. So there's always the element of how do we allow individuals to still keep private whatever choices they're making and only allow them to be able to disclose when they choose to. And unfortunately, because women are still disempowered, and many young women, it depends on what their partners want, what the mothers or older relatives of the partners have to say about it, this makes a difference. Now that I have the microphone, one last story. A young woman that I met in one of the villages, fishing villages, she was 16. It was her second pregnancy. She was HIV positive. She did not know the status of her partner. She could not get him tested, and she was afraid to take home antiretroviral treatment. That's the reality.
Elizabeth, that is a sobering end to what's been an absolutely fantastic session. So thank you to Paula for giving us the reality check and maybe pointing a way to the future with integrating HIV, to Pontiano for telling us about the HIV epidemic, but also that magic collaboration between clinicians, scientists, and government, which can really work. That was brilliant. Elizabeth, for telling us about the pioneering research that's happened here in Uganda and in Kenya in prevention, and really great congratulations for all of that. And then Francis, for taking us through the pioneering work that you've been involved in treatment as well. And Julius, for giving us a sense of how well you're doing with surveillance. And I love that community engagement, the fact that you're getting the training to really get grassroots early warning systems. It was fantastic. So a great session. Thank you, everybody. Enjoy your lunch.
And thank you very much to you, Sheena. That was fantastic chairing. I'm here. Yes, it's hard often to keep everyone to time. So thank you very much, and thank you all to the speakers. Do please join us for lunch. As you exit both sides and as you go up, there'll be a little sort of coupon for lunch. Please make sure you have one. Lunch is up the stairs. There'll be people to direct you. We are desperate to get back on time, so please, can we be back in the room at 1:50? And yes, do please enjoy your lunch. Thank you.
Thank you. Just from that experience, it's a big room to manage roving mice with only 10 minutes for the questions. I don't know whether it would work to have everybody do the time. Yes, I think so. I think it might work well. And then I think for the chair, if those mics work, for the chair, it would also be easier. Yeah. Okay. Thank you.
Thank you so much.
You're very, very welcome.
Hello. I am co-chairing the next session.
Yes.
I was wondering.
Oh, and I have something for you.
Hello everybody, just to let you know that this room will be monitored and or locked, so you're free to leave your laptops and such in the room should you wish to. Thank you. Yes.
Hello.
Hello, everybody. Welcome back from lunch. I hope you've all had a lot and enough to eat and drink. Please, if you wouldn't mind taking your seats, in the interest of time, we're going to make a start. We have our two fantastic chairs, David and Teresa, and we also have our first speaker. So we'll make a start, and everyone else will realize and join soon. So I'll just hand over to you. Thank you so much, Teresa.
Hello, everybody. I'm only ever called Teresa if I'm in trouble or doing something naughty, so please call me Tess. I'm based in Oxford. I know Adrian very well, so it's my absolute pleasure to introduce the next speaker, Professor Sir Adrian Hill. He is the director of the Jenner Institute, which was founded in 2005. As long as I've been in Oxford, I've known Adrian for being a pace setter in the field of malaria, and I think that continues to this day. He was instrumental in the Oxford AZ COVID-19 vaccine as well, and is now turning heads with his new vaccine. So I hand it over to you, Adrian.
Great, thanks very much, Tess. I could try speaking to that slide, but it won't be very illuminating. Have we? You're going to share. Great, thank you. Terrific, thank you very much. So thanks for that introduction, Tess. What she didn't disclose is that she and I come from the same hometown and went to university in Dublin as well. So thanks for the introduction. I'm going to take you very quickly through, and I know a lot of you are virologists, something a lot bigger. A protozoan parasite, and a year or so ago, we had no licensed deployed vaccines for any parasitic disease of humans. And I guess one of the reasons I'm here is that that has now changed. And in fact, the better of these two vaccines, I'm told, arrived in Uganda just a couple of weeks ago. So this is very much the story of R21, which is the name of that malaria vaccine. And I'm going to take you through a little bit of context and specifically focus on a forward-looking question. We have vaccines now that are good at preventing disease. Can we do something about getting rid of that disease, which I will argue at the very end should be highly cost effective? So, malaria, the problem. 500,000 deaths a year, mainly young children, some pregnant women, some travelers, etc., etc. Most of those deaths, it says 90%, huge proportion in Africa. Before we had vaccines deployed, we were spending about $500 million a year controlling malaria. I'll show you what that looks like in the slide after next. And as I've told you, vaccines were rolled out for the first time last year. This is a graph, if you can read it, of 1980 to 2023 on the x-axis. And you can see that for some diseases, we've made huge progress, particularly lower respiratory tract infections, HIV being controlled better than it was without a vaccine. But what's clear on here is that that third line from the top, if I can point to it, yes I can, almost. Flat line there in green is malaria. And despite spending $500 million a year, it wasn't really changing for decades, right from the 1980s until around about now. So can we do better? Can we introduce new tools? And I'm going to suggest that as well as vaccines, there's another new tool coming along fairly soon, I hope, that will make a big difference. So, why has it been so difficult? Well, parasites they're bigger. People have been trying a long time. Here are two Algerian Frenchmen, actually brothers, working in Algiers back in 1910. And this is the first reported paper of a malaria vaccine attempt. So it's taken well over 100 years to get vaccines to work for any parasitic disease. I counted 145 different vaccine candidates going into people, into clinical trials. a few years back. It's probably over 150 now. So this is my way of saying this has not been an easy task. And to rub that point in, have a look at this. This is from 1880, when the parasite was discovered, to 2020, when we finally, or 24, we finally had a vaccine. It's been the slowest campaign, if you like, to make a vaccine for anything ever. Look at tuberculosis, 1920, there was BCG, and all the others, except HIV, which I think will be a little while yet. But look in the bottom right-hand corner, just to show we're not complete slouchers in Oxford. We did manage to make a COVID vaccine in less than 140 years. So, what's the problem? Why is it so difficult? Well, as you know, whole parasite vaccines can work, but only up to a point. You need subunit, new modern technology. Some people like mRNA vaccines. You need to pick the antigen, which is fine because COVID had 12 and everyone picked the same one, the spike protein. That was quick. Malaria's got more than 5,000. It's got 4 different stages to the life cycle with different antigens at different stages. That's the second point there. It also has antigenic variation. One protein on the surface of red cells swaps around like in trypanosomes. And even worse, COVID had maybe a few months to think about our immune system to avoid vaccines and immunity. Malaria parasites go back at least 30 million years. If you root the phylogenetic diversity of malaria parasites at the blood stage, they've been around for a huge amount of time and have evolved ingenious ways of dealing with our immune system. So these are the 4 stages of the life cycle. The good news is I'll mainly be talking about one. So you only need to remember sporozoites. These are the things that are injected by the Anopheles mosquito into your arm. They go fairly quickly to the liver, hang out in liver cells for a week before producing the blood stage parasites that then cause the trouble and give you fever and, if you're unlucky, death. I will mention RH5. Have a look at that. That's the new kid on the block and looking very exciting, and it's a blood stage antigen. But let's focus mainly on sporozoites and RH5, a little bit of transmission blocking, which happens in the mosquito midgut. So one of the things we've learned the hard way is that to get protection against malaria with vaccines, you need levels of antibody. We don't call them neutralizing antibody, we call them functional antibodies that are 10 to 100-fold higher than your average vaccine, say a meningitis vaccine. So that's been one of the big problems. You need high levels of antibody and you need it maintained. If they drop off in months, then your vaccine lasts only for months. Cellular immunity, we can get partial efficacy. We spent well over a decade trying to do that. But as you can see here, the T-cell inducing vaccines at the moment are off the slide because we can't kill the last infected liver cell with most of those vaccines. So what is the good news? The good news is that these are the 2 vaccines that are out there now being deployed. They both use the same antigen, the circumsporozoite protein, that rather helpfully in the middle has this run of repeats of just NAMP, 4 amino acids, repeated 20 to 30 times in all Plasmodium falciparum parasites, the ones that kill you. And for about 40 years, people have tried to get antibodies against this repeat, and it's been super difficult. You need very high levels. And these are the 2 vaccines. They both have the repeats, as you can see there, RTSS from GSK, the first malaria vaccine, starting life in 1984, licensed again last year, and R21, which is our homegrown variety. The big difference is that the RTSS vaccine is mainly hepatitis B. Ours is half hepatitis B, but it's not like 20% of hep B. And the reason the hepatitis B was necessary is, some of you know, that spontaneously produces a virus-like particle or nanoparticle, whichever you prefer to call it, that is 20 nanometers or something in diameter, and that's exactly the size that your immune system likes to gobble up macrophages or dendritic cells and produce a very strong immune response. So here are the 2 vaccines. Let me take you through these a little slowly. So I told you there were nanoparticles. There they are. There's our R21, there's the RTSS. starting life back in 1984. It was a 40 years development plan. Kudos to GSK for hanging in there. In the 1980s, when you were expressing this in yeast, you needed the excess of hepatitis B to allow the monomers of the fusion protein and the hep B to assemble into nanoparticles. Many years later, this is Kath Collins doing her PhD at the Jenner Institute in Oxford in my group, managed to express just the fusion protein. And lo and behold, the whole nanoparticle is covered in malaria, not most of it with hepatitis B. And the consequences of that, I won't show you the data on, but very simply, a lower dose works, 5 micrograms, not 25 micrograms. It's cheaper by a factor of 2.5. Higher efficacy, I'll show you that. Immunogenicity just over doubled. Someone's battery is running low, unfortunately it's mine. Better durability, lasts longer, and 20-fold more supply because it's easier to manufacture in a suitable yeast strain. So, even though GSK had been around for years, in 2010, we looked to see if we could get R21 moving. And the answer is yes, because we worked with these guys who are actually the world's biggest vaccine manufacturer. They're in Pune, in India. They produce over half the vaccines that come to Africa by doses counted. Their costs of goods are remarkably low because of that very high scale, and that's exactly what you want for a disease of largely low-income countries. This is the other hero of this story, who's Halidou Tinto, across in Burkina Faso, designed the first phase 2 trial, very simple, control rabies vaccine, R21 with 50 micrograms of the adjuvant, or 25 micrograms of the adjuvant. I'll come on to the matrix M in a moment. These are the data, those are the controls, rabies vaccine, mostly getting malaria. The blue line is the higher dose of adjuvant, and that's a bit better, 77% efficacy. Important because the WHO had been saying for years, we'd love to have a vaccine with 75% efficacy against malaria. RTSS was closer to 50%. And the higher dose of adjuvant improves the efficacy a little bit, but significantly so. So we stuck with that. Is that better than RTSS? Well, yes, we would show this. RTSS gives you a 44% efficacy, and in the first phase 2 trial, 77% efficacy for R21 matrix M. And then over 4 years of follow-up, because we started that way back in 2019, pre-pandemic, the efficacy over 4 years in Burkina Faso in phase 2 was over 4 years was 64%, and the same for RTSS, 36%. So we have a more cost-effective vaccine. It's not just under half the price, it's getting close to being twice as protective. So, the key phase 3 trial followed, 4,800 children, 2-to-1 randomization, vaccine to control vaccine. Maureen Datto, the clinical lead in Oxford, and the 5 stars of the show in different places in Africa, Ali Olotu, Alassane Dicko, Jean Bosco Ouedraogo, Manga Hamaluba, and Halidou Tinto again. And that's simply the design. I just point out that in some of those sites, malaria is very seasonal, as in Buguni in Mali. In other sites, it's more perennial, and we wanted to test the vaccine in both cases in case people thought, well, in a seasonal site, you only need short-term protection. And the punchline on this slide, after just a year, 79% efficacy at the seasonal sites, 75% of the standard sites, not statistically significantly different, probably is a little bit different, really, but only by a small number of percentage points. And because I'm going to end in a moment with elimination as a target for vaccines, take a look at this. This is in the kids, where only the children had been vaccinated, right? Young children from 5 to 36 months of age. What we're measuring now is not clinical malaria or disease, we're measuring the presence of parasites in the blood. And at 6, 12, 18, and 24 months after the course of R21 vaccine, you get 65% in the first 6 months, 50% in the last 6 months, a useful level of control with a single component antisporozoite vaccine that has encouraged others, and you'll hear about them in a moment, to take this on as an elimination vaccine. In the meantime, a huge amount of work by WHO and national governments deploying this vaccine for the first time has led to this slide. All these vaccines are being deployed in different countries, as shown here. don't ask me or me to explain why some countries get the very good vaccine and RTSS goes to other vaccines. We don't decide that. Some very brilliant people in WHO do. But what I'm showing you here is that we have, whoops, we don't have anything unless we have a charger. It's not my laptop. Thank you. Are you going to change laptops? All right. Oh, you have it right there. That's fantastic. Let's pop that in there.
So it's this?
It's that one, yep. Brilliant, thank you. Great, I've never done a two-computer talk before. This is new, right. So this is what's going on right now. It is a trial. It's a post-licensure trial. It's a phase 4 safety and efficacy trial. That's required for all vaccines. You may not have noticed. But to look at real numbers in the real world, WHO again have picked, with the Serum Institute of India, Uganda, actually 2 PIs in Uganda, only one at the other 3 sites, Professor Kamya and Canberra, Ivory Coast, Ghana, and Nigeria. So we don't know how many people will be in this trial because it depends on the number of cases. But you're asking now for severe malaria protection and protection against deaths and obviously safety data in many thousands of children. And that will be kicking off, hopefully, in the next few weeks to months. There are other trials going on. In fact, one has happened here in Uganda, a phase 1b trial in children living with HIV. Immunosuppressed a bit from that virus, but we were delighted to see, and this was the question we were asking, are the immune responses the same in the HIV positive and HIV negative children? The HIV positives are under treatment, and the antibody responses are non-significantly different. And that's very encouraging because the vaccine should work in these children. We're starting tomorrow, I believe, in Mali, a childbearing age woman trial with the same vaccine, R21. And there's an exciting elimination type trial already up and running in the Gambia and Burkina Faso. I'll come to that in a moment. And a very similar trial kicking off in Bangladesh in the last few weeks. So in summary, next steps of development, those pre-pregnant women, and then hopefully soon afterwards women who are pregnant, RH5 coming along very fast as a leading conserved blood stage antigen. Most of the blood stage antigens are horribly polymorphic. RH5 is conserved, and there are data I'll come to in a moment about the efficacy of RH5. The elimination trials I've mentioned, and then a combination of R21 and a transmission blocking vaccine, and there are 3 to choose from. I won't go into detail. That should be key to elimination. So, my view on how you eliminate malaria is to take all the existing tools and add vaccines. Ideally, a 3-component vaccine, R21 we already have, RH5 coming out fast on the rails, and mosquito stage antigens that are in trials in Africa. They're just a bit harder to test for efficacy. So spelling that out, we have a licensed vaccine, antisporozoite. RH5.1 in a preprint you can see online showed 58% efficacy against blood stage malaria. If you count the high-density parasitemias, which is the ones likely to cause death, it's just over 75%, which is really exciting. And there's a trial going on at the moment, guess what, combining this one with that one. We do collaborate in Oxford quite a lot with our competitors. So, transmission blocking vaccines, several of those available in trials in Africa. They started later, of course, and they'll take a bit longer, but rather helpfully, the Serum Institute of India has in-licensed essentially all of these, which means that you won't have companies fighting against each other. You want a triple mix. So very briefly, what's happening in the Gambia and Burkina Faso? This is a MRC-funded trial, or UKRI, if you like, the first ever trial that is cluster randomized in villages in both the Gambia and in Burkina Faso, up to about 15,000 children. Coverage rate is pretty good. Umberto D'Alessandro, who cooked this up, will tell you, working with Tinto in Burkina Faso. So coverage of the whole population above 70%, and he's just at TropMed a few months back released the initial data, which looks really encouraging. higher efficacy than I had dared to hope. I won't show you his data, but look out for that. He has told us already high efficacy in adults as well as in children. That was a gap in the story. So where next? We don't know. I think what you've got to do with a transmission blocking vaccine is start in the easier places where transmission is lower, the outside of the continent, moving inwards to DRC and other places that will be more difficult. Bioko Island, west of Equatorial Guinea, or at least the mainland, are very interested. We're talking to them about a trial there in collaboration with MCD. Zanzibar, a much larger island, about 1 million people. We're talking to Roly Gosling at the London School about trials there with and without other interventions. So the state of play at the moment is that we are trying in stage 1 to optimize a low-cost, high-availability 3-stage vaccine that I've just talked about, show increasing impact with added vaccine components, longer-lasting drugs, and that's super exciting. There is a drug in a trial in the UK, phase 1 at the moment, from MMV, that it lasts at least 3 months from a single intramuscular injection, maybe 6 months. The trial's ongoing. Combine that with a vaccine that can last years, I think then you're really getting serious about eliminating a lot of parasites. There's the name, MMV 371, and then select the right settings. I've shown you some of the ones we would like to start with. But my final point is, I think, the most important. Look, let's be frank, it's going to take a hell of a lot of money to eliminate malaria. Everybody from Jeff Sachs 25 years ago to MMV in the last few months have estimated how much that might be. And we don't know, but it's certainly of the order of not billions, but tens of billions, let's say 15 billion, to get rid of malaria in Africa, and that's just falsiparum. What's calculated here is the economic benefit you would reasonably expect from eliminating malaria in this continent. And there's the number, 127 billion between 2015 and 2030. Okay, we're overdue, we're in 25, but the point is the same. You will more than get your money back. Forget about the health benefit for a moment. This is GDP increase from a healthier workforce, from kids who don't get malaria all the time, whose parents have to take time off work, all of that counted in. You get your money back big time. And the funding agencies know this. The simple problem is there aren't too many agencies around who have 15 billion in their back pocket. And they don't all, or none of them has to do it all on their own. We need a consortium. We're working on that. So, in summary, malaria elimination is back on the global health agenda. It was on the agenda, funnily enough, in Nigeria in 1958. Didn't quite work out. 2 antisporozoite vaccines are newly licensed, and a blood stage vaccine should be soon, and also transmission blocking vaccines. Initial elimination vaccine trials have started, others will soon. Already in the Gambia and Burkina Faso, Bangladesh last month, Bioko hopefully soon, and newer, longer-lasting anti-malarial drugs will complement those vaccines, probably be given as a mixture if everything works out in achieving elimination. And as I emphasize, this is an expensive goal, but succeed, and the money is recovered many times over. I could spend the next 25 minutes acknowledging people. I'll just mention the leaders of the teams in the phase 3 trials. You've seen their photographs already, Ali Alassane, John Bosco Manga, and Haladu. Lots of key people at the Jenner Institute, Marine Datu on the clinical trial side, Lisa, now our senior immunologist, Sophie, Fernando, and Alison Laurie, and the amazing manufacturers in Pune at the Serum Institute of India. Thank you very much.
Thank you so much, Adrian. I know you have to dash off, so we won't invite you on the stage, but I might take this one opportunity to ask you a very low-hanging question. Apart from money, what is the one thing that you could put your finger on that will enable a 3-stage vaccine best?
Well, there are lots of potential problems. That you've got to be able to mix them to make it useful so they don't interfere with each other. One of the things I think we've kind of achieved is not having, I don't know, Sanofi Pasteur making a blood stage vaccine, Merck making a sporozoite vaccine, somebody else in China making a transmission blocking vaccine, and they all competing with each other. So because the return on a malaria vaccine is pared down to being pretty minimal, meaning you have to manufacture very inexpensively to make a tiny product, we've got one big company, actually the world's biggest company, as I said, at manufacturing vaccines, focusing on malaria. And that's all due, not all due, a lot of it's due to the boss of the company and the owner of the company, Cyrus Poonawalla, who decided this was going to be his big play for posterity. Long may that ambition continue. Thanks very much.
It is now my pleasure to introduce Dr. Mazaba, who is the Regional Director for Eastern Africa at African CDC. They are a public health leader with over 28 years of experience in virology, epidemiology, and pandemic preparedness. They also established the Zambia National Public Health Institute and have a hugely impressive co-authored publication of over 160 papers. So we'd like to invite them to the stage.
Good afternoon, everyone. I know you had a sumptuous lunch, but some of you might have seen me sitting there and trying to scrap some food into my mouth, having had meetings one after the other, but I guess it goes with the position. Indeed, it's a privilege to sit and be among great minds in science. In my previous life, 4 years ago, I was in this space and I do miss it. Well, how can I start this story? 2014, 2016, West Africa Ebola outbreak devastated many of the countries in the western region of the continent. Solution? No vaccines, inadequate therapeutics. The story of Africa. COVID-19 hit 2019, 2020 in most of the African countries. Again, same situation. Not enough vaccines, not enough therapeutics. Getting everything at the tail end of the chain. But today I met two wonderful ladies, and they were talking to me about development of vaccines, and they're in the forefront. I think that is really exciting for Africa, isn't it? Oh, come on, guys. One of my responsibilities is talking to people, but I love it when people are enjoying me talking to them. So please give me a smile as I take you through my presentation. So really, just for those of you who don't know much about the Africa CDC, a lot of times when I'm saying, oh, I'm from the Africa CDC, they'll be like, oh, so you're part of the American CDC, and I'm like, no, we are the African CDC. So just to remind all of you that the Africa CDC, similar to the US CDC, similar to the China CDC, and so on and so forth. But in this case, it is an autonomous health institution under the Africa Union, meaning its establishment was moved by heads of state and government in the Africa Union. And really, its role is to support public health initiatives within the member states and strengthen the capacity of their public health institutions to detect, prevent, control, and indeed respond quickly and effectively to disease threats. On this slide, I'll just push you to the aspiration of the Africa CDC, which is to become a world-class, self-sustaining and agile institution that champions Africa's health security, set the Africa public health agenda, and lead and coordinate continental efforts driven by a One Health approach. Of course, with the member states deciding what the priorities are and how we move that agenda. This is just sort of some background to bring us, to the fore on the context of our health situation in the continent or on the continent. We saw, for instance, in 2024, this shouldn't be current because that's last year, but in 2024, we saw 152 public health events. In 2022, we saw 213 public health events last year, and we anticipate more outbreaks this year if we don't change how we do things on the continent. And in this space, like I said earlier on, we've seen a lack of medical countermeasures, including things like vaccines, therapeutics, diagnostics, and so on and so forth, challenging how we respond to the health emergencies, but even to those diseases that we feel are endemic. We were just talking about malaria. I think we're so used to having malaria on the continent that we haven't been really pushed to ensure that we eliminate it, even as we speak about elimination. We talk about insufficient human resource. We talk about weakness in our health systems, and I think the continuous outbreaks that continue to hit us are an indication of our weakened healthcare systems. But we're also happy. I think today we heard from the minister how Uganda has responded to the Ebola outbreak, for instance. We saw how Rwanda responded to the Marburg outbreak. So it's not all hope lost. In fact, we're excited because I think the Africans are also pushing the agenda. So we continue to see a lot of, pandemics, epidemics, outbreaks hitting us. And we feel that this has a, serious implication on, not just the physical health of the people, but the economies of the country, so affecting, various factors and bringing in issues of political instability. So why is the Africa CDC trying to push, vaccine development on the continent? Like I said earlier on, we are totally dependent on external vaccine suppliers. We import over 99% of our vaccines to the continent. And sometimes that has affected even how our population are recipient to vaccination. We've seen how in many spaces we've had to push and fight and persuade our population to have the vaccines taken, to improve the vaccine uptake. We saw in the COVID-19 pandemic the need for local vaccine production to enhance health security on the continent. And Africa CDC's new public health order does prioritize vaccine self-reliance as indeed a strategic goal, reminding you again that all these insights are determined by the member states from which you come and shared concerns on the continent. So we are pushing the agenda. Let's manufacture vaccines on the continent. But we still have a number of things that we need to sort out. We see that there's fragmented markets with varied regulatory requirements. Prof just talked about how you have all manner of vaccines for the same disease and so on and so forth. We have limited government procurement commitments for African manufactured products. We've heard when we've engaged with those who have already started in this space that they are concerned that they don't have a market adequate to sustain the development of these vaccines. We've seen limited access to technology and know-how, slowing down the development of new products and indeed building of skills. Also, in addition, we have noted a gap in accessing appropriate financing. I think that's the elephant in the room in the last few months, financing, and financing. But we also see a gap in specialized workforce across the value-added chain. Again, appreciating those who are already on the chain and moving this agenda. Maybe just to also give context, when we look at the pharmaceutical market, 40 to 60 billion per year has been utilized to procure vaccines. And in 2024, it was projected to reach 60 billion. I haven't looked to check if that's what it did reach at that time. But what is important to note now is that we have 1.4 billion people on the continent. And by 2040, we'll have about 2.5 if things move the way they should. With 574 manufacturing facilities. But when you look at places like China, they have 5,000. India, 10,500 facilities in this space. So the market on our continent is still adequate to allow for manufacturing to take place on the continent. So just to emphasize the vision of the Africa CDC and the member states in the Africa Union, we're hoping that by 2040, 60% of the locally produced vaccines are produced on the continent. And Prof, this is a challenge to work with us to ensure that we are able to manufacture those vaccines that are being developed through methods that I'll discuss with you shortly. We need to address supply chain vulnerabilities and ensure timely access to life-saving vaccines for our people. And we need to support in developing regional manufacturing hubs. Just to focus on the pillars of the Africa's vaccine manufacturing strategy, we're looking at 5 areas, and this is strengthening Africa's vaccine, research and development, and production capacity, and I'm excited really that this has already started. We're looking at pushing regulatory harmonization and indeed quality control. Public-private partnership for sustainable vaccine production. We can't do it ourselves. We need to partner with those who've already got the experience, who've got the facilities to work with them. Workforce development and capacity building also remains key, and we need to ensure that there's equitable access and distribution of these vaccines. So our focus really has been, we have 7 priorities, but priority number 6 talks about expanded health products, technology, innovation, and indeed manufacturing. So some of the things that we have pushed, the agenda we have pushed as the Africa CDC, is to move the platform for vaccine manufacturing and upgraded it to a platform for harmonized Africa health products manufacturing. So beyond vaccines, we're looking at other therapeutics, we're looking at diagnostics and so on and so forth. The AU made a decision on the African pool procurement mechanism, putting together Africa CDC, the Afrexim Bank, and indeed UNECA, that as we move towards improving our capacities to develop and manufacture the vaccines of the continent, we still need the vaccines, right? So we need to get the vaccines onto the continent. And I think the pooled procurement system also helps in the COVID-19, bringing the vaccines closer so that distribution is easier and more equitable. The Africa CDC has also signed an MOU with UNICEF and PAHO to accelerate the agenda of local manufacturing. And also, one of the things that we've supported in doing is accessing finance, and 1.2 billion has been secured from AVMA and 2 billion from Afrexim Bank in June 2024 to support this agenda. We've definitely assisted in upgrading or updating the Africa manufacturing landscape with the 574 manufacturers and 25 of them focusing on vaccines. Procurement of medical countermeasures for outbreaks, including the vaccines that we keep talking about, the lab supplies and diagnostics and therapeutics is indeed part of this agenda. But I think what is important to note is the different functions, the core functions of the platform for manufacturing. We're looking at issues of product scope, the quality assurance, which is key, the interface between the developers or the producers and those to buy those vaccines, the financing and indeed governance. So maybe just to give you background, a little bit more background on the supply landscape. We saw in 2024 that there were 25 active vaccine manufacturing projects on the continent, which can then be divided into various categories based on overall supplier manufacturing and capabilities. So we have 3 segments, and in segment 1, we saw 5 suppliers who have commercial scale facilities, and tech transfer is underway to support development on the continent. And in segment 2, we see another 5 suppliers which have commercial scale facilities and are qualified and ready to receive a technology transfer from the global north. The remaining 15 suppliers are in segment 3 and are still in developmental stages. So we need to be able to rationalize the projects, recognizing the ongoing need, as the long tail of the pipeline projects may face challenges to gain a viable market share. We need to make that decision to make it viable. We have also recorded 8 antigens being expected to achieve WHO's PQ and enter pre-qualifier and enter the continental market between 2025 and 2030. Most of them from South Africa, but we also have Cameroon in that space. I think one of the challenges that we've had is really around regulatory regulations, the regulatory frameworks across the member states. And so as Africa CDC, we're pushing to strengthen this space through mutual recognition against WHO maturity and national regulatory authorities on the continent. So in 2025, a number of MOUs have been signed, and this will benefit the continent. We're looking at efficient regulatory processes, shared assessment reports, lab reports. We're talking about the GMP, earlier on GCP inspections, and reduced duplication and enhanced efficiency. We're pushing an agenda on timely access to medicines, accelerating approval and availability of essential medicines, vaccines, and medical devices. Indeed, collaboration remains key. It's the game changer, and this promotes scientific cooperation while maintaining regulatory independence. We're also looking at optimized resource use, supporting the NRAs with limited resources by leveraging strong regulatory agencies. Ladies and gentlemen, I know most of you in here are scientists, but somebody has to speak about this. So allow me to also talk about, further talk about the regulatory strengthening and how we're approaching that. We are working with WHO on streamlining the pre-qualifier process and prioritizing reviews of African manufactured products. There's AUDA, NEPAD, also promoting regulatory reliance among the African NRAs and supporting control labs. Technology transfer remains key. While we know we have a lot of young people and medium-aged who are very innovative, but sometimes why reinvent the wheel? So we're willing to push an agenda on technology transfer so that we can find a space to manufacture what we need at a more cost-effective manner and also assure access in good time. We talked about the workforce and there being a gap, and so one of the things that the Africa CDC has done is to launch a regional capability and capacity network to drive skills development, workforce training, and indeed R&D. This will address definitely the workforce shortages in biomanufacturing, R&D, and regulatory affairs. It will connect the key stakeholders, establish structured, sustainable training programs to build local expertise. This network will also expand hands-on learning experiences and skills manufacturing in biomanufacturing, R&D, and regulatory affairs aligned to Africa CDC's vaccine, research and development, and indeed manufacturing competency frameworks. This network will support long-term workforce development, which is much needed. And so we have secretariats in 4 of our regions, in North Africa, East Africa, West Africa, and Southern Africa. The Africa CDC has started to collaborate with the ACFTA to see how we can facilitate trade and supply chain of manufacturing raw materials and input materials for the stakeholders on the continent, and ensure market access to African-made products and strengthening regional procurement and distribution networks. In terms of access, again, we're working closely with Gavi to operationalize a 1.2 billion USD AVMA initiative, and with the bank, to move an agenda on pharmaceutical manufacturing facility product to implementation worth about 2.5 billion has been pledged. So what are our priorities for 2025? So the health ministers who represent the member states in the Africa Union at the second Vaccines and Other Health Products Manufacturing Forum brought out these recommendations, and I hope that we all buy into them. We need to enhance demand certainty by securing procurement commitments from Africa-made vaccines and health products. We need to operationalize the APPM, improve affordability and equitable access, support the AMA and MRC to streamline approvals and facilitate WHO pre-qualifiers, unlock financing, and we are still warm to the support by Gavi in replenishing the financing, addressing workforce gaps in biomanufacturing and tech transfer, and calling for a tailored funding and G20 support for science and technology. Strengthening of post-vaccination surveillance and counter misinformation. I think we all agree that there's been a lot of misinformation, and I think we learned that from the COVID-19 around vaccines. We also need to promote trade and reliance on African-made health products. And the 9th communique note was that Africa CDC needs to align with PAM for resilient, self-reliant health manufacturing. So as I come towards the end, what is our call to action? Ladies and gentlemen, Africa needs to lead the agenda on local manufacturing and not to be led, always be led by other partners. We need to learn from those who started before us and are good at it, but we also need to lead the decisions on our continent. We remain committed to supporting the countries and achieving vaccine reliance. We're calling for increased investment in Africa-led vaccine research and development, and appreciate all those partners who are on the logos there for supporting this agenda in our countries on the continent. But strengthening collaboration among governments, research institutions, and private sector. And I think we've seen good collaboration when we looked at the MRC, UVRI, and the London School, pushing the agenda on collaboration, and I think that is really appreciated. As member states in the Africa Union, we need to concretize our commitments by prioritizing African-made health products in their procurement policies and indeed decisions, and accelerating technology transfer agreements and investing in biomanufacturing and infrastructure. We need to invest. You can't go begging with an empty basket. We need to have something in the basket and asking for a top-up. We would like for us to continue collaborating with the AMA to streamline approval processes and indeed be the front-runner, support the front-runner African manufacturers to overcome the barriers to market entry and secure of commercial contracts. As I conclude, allow me to read and emphasize that achieving vaccine self-sufficiency is essential for Africa's health security. By investing in research, regulation, and local manufacturing, we can indeed reduce dependence on external supply. So Africa CDC is committed to working with the partners to ensure vaccines address Africa's needs and contribute to global health equity. So the vaccines we want to manufacture and the therapeutics should not just be for the African market, but should be accessed by everybody in the world. Thank you very much. Asante sana. I think there are some French people. Merci beaucoup. Shukran. Obrigado. And now I have to say this correctly. Oui balenyo. Thank you.
We have many questions online. Oh, wow. Sorry, these are all for Adrian, who has just left, so apologies. I have one question. Thank you so much for such a comprehensive and whirlwind tour for everything that Africa CDC is doing. Really impressive. Do you see the Do you see the journey for therapeutics and for diagnostics being the same as for vaccines? Will there be similar bottlenecks, challenges, or do you think it'll be easier once everything is cracked for vaccines?
So certainly, I think the journey on therapeutics has moved. We have, quite a number of therapeutics, except they are basic therapeutics. So you have the paracetamols, the basics, but we haven't reached the stage of, for more serious infections or conditions. But I do believe that if we have a breakthrough, the vaccine space, I think, is more, is heavily technical, but also requires a lot of resources, not just financial resources, but even the infrastructure, the workforce, and so on and so forth. So I believe that if we have a breakthrough in this space, then everything will be easier. Thank you.
Thank you so much. So apologies to the online participants for all of these questions for Adrian Hill. Unfortunately, I just saw him leave. I could make up the answers, but I don't work in malaria, so I'm not going to do that. So it is my pleasure to introduce the next speaker, Dr. Sheila Belinda. She is the Deputy Theme Head of the Vaccines Research Theme and is a molecular virologist at MRC, UVRI, and LSHTM Uganda Research Unit. She leads the Ugandan vaccine development for both COVID-19 and for CCHF, and it's my absolute pleasure to introduce her.
Thank you very much, Tessa, for your kind introduction. My title for the presentation is Development of Vaccines for Africa in Africa, however, with a deeper dive into the Ugandan context. Yes, my outline for the presentation is an introduction. However, I would like to thank Lucy for that comprehensive introduction you've provided. My presentation will just fall right in the middle of that. Thank you very much. I will then show the progress that has been made for various platforms that we have set up at the MRC as well as the UVRI, and then I will highlight the next steps. So as you all know, efforts towards, or majority of the vaccine development efforts in Uganda started during the COVID-19 pandemic. And this initiative was initiated by the President of Uganda through the Presidential Scientific Initiative on Epidemics. Okay. So this was led by the senior scientific advisor to the president at that time. She's currently the Science, Technology, Innovation Office of the President Minister. And at that time, she called sessions of key stakeholders for brainstorming sessions across 3 different areas. These included diagnostics, therapeutics, as well as vaccine development. And she invited key stakeholders who included academic institutions such as Makerere University, research institutions including the Uganda Virus Research Institute, as well as the MRC, UVRI, London School of Hygiene, and Tropical Medicine. And during these brainstorming sessions, the UVRI and MRC were awarded 3 platforms. And this was basically because of the capacity that we have developed over the years in terms of infrastructure that we have available, that is the laboratories, the equipment, additionally, the human resource. As Professor highlighted during his presentation this morning, we have had significant experience and exposure to cutting-edge technologies working on HIV. As you recall, at that time in Uganda, we had about over 165,000 cumulative cases and greater than 3,600 deaths as of December 2022, compared to what was happening globally as highlighted. And again, in Uganda, the mainstay of our public health response was mainly around non-pharmaceutical interventions such as hand, oral, facial hygiene, and an extended community quarantine. As you all remember, it was about 2 years, affected education and other sectors as well. While elsewhere in the West, communities had almost resumed normal social activities. For example, in the UK, they had achieved significant vaccine coverage of about 80%, 75% and 60% for first, second, and booster doses. While in the sub-Saharan countries, as Lucy highlighted, we had only about 18 fully vaccinated, and in Uganda, only 41 had at least received 1 dose, and about 28 were fully vaccinated by December. So this presented a great opportunity for research and development in sub-Saharan Africa because of the limited access to vaccines, as well as the variants that we experienced. For example, in Uganda, following the Wuhan, we had a unique one, the A23.1. It was only in Uganda, evolved, but did not spread greatly. And then, of course, at that time, the long-term vision was anticipated economic growth. This map just re-emphasizes what I have mentioned in my previous slide. It was from Our World in Data around June 2021. As you can see, the African continent, limited vaccine coverage, including Uganda here. So I will now quickly start with the adenovector vaccine platform, of which I'm the lead investigator and work with a large team, multidisciplinary. So we started from the very beginning. We collected chimpanzee samples or fecal samples from 2 sanctuaries in Uganda. That is the Uganda Education Center as well as Ngamba Island. In addition, we collected some fecal samples from the wild Hoima Forest Reserve because we wanted to have a breadth of representation of what we had as adenoviruses. We sequenced these, we of course subjected these to laboratory procedures, including nucleic extractions as well as purification, and then sequenced these and compared them to what was available globally. And we realized that the adenoviruses that had been isolated in Uganda had a different lineage to what was already available globally. We then also amplified, focusing on the strains that had been circulating in Uganda at that time. As Adrian highlighted, for COVID, it was straightforward. It was the spike region. So we amplified the entire spike region of the viruses that were circulating during this time. And using metagenomics as well as cloning, we were able to generate a novel backbone that eliminated the E1 gene that is responsible for replication. And then also, using cloning strategies, we inserted the entire spike region and generated vaccine constructs. So here, on the right-hand end, we are just showing how our chimpanzee adenovector, the empty one that we've generated, behaves in comparison to other vectors that are already available, even with a spike of Omicron inserted here. So as you can see, this is our vector with a spike gene inserted. This is when it's empty in green, and we've compared this to the human adenovector right here in brown, using, of course, CPE and a number of days in 29A3 cell lines. So those results in vitro encouraged us that our adenovector, in addition to coming from viruses that may be belonging to a different lineage, is also working well in comparison to what is already available there. So the next task for us was to see how relevant this adenovector backbone we have generated is to the Ugandan population. So we collected about 1,200 samples, sera samples from approximately 81 districts in Uganda, and we tested for pre-existing immunity of the population to the adenovector backbone that we had generated. And we, at this point, determined the point prevalence for 2 adenovector backbones. We have 2 variations of the same construct. So for one, it was less than 5, and for the second one, it was less than 11, which is all within acceptable ranges. However, we noticed from our data that more neutralizing antibodies were observed in Kasese district, whereby the population in Kasese has previously been exposed to adenoviruses that are very similar from the one that we used to generate the backbone. We then moved to test our vaccine constructs preclinically, that is in mice. This is a collaborative effort with Makerere University, College of Veterinary Medicine and Animal Resources and Biotechnology. And so here we worked with 2 strategies for the pilots that we have completed, the 7-day interval strategy as well as the 14-day interval strategy as highlighted in the figure. At both points, you immunize or vaccinate the mice. At some point, you need to sacrifice some, collect the samples to allow you, tissue samples that are going to allow you to do further analysis in the laboratory. So our design was, for what I'm presenting here today, is we worked with 75 bulb C mice. They were aged about 7 to 8 weeks, and we blinded, it was a randomized blinded study, and the reason is because what we are working on has intellectual property, so we did blind, although it's not really a requirement for my study. And of course, we ensured that the females were not pregnant. We have since then unblinded and have the results that I'm showing in my next slide. So we did test the effects of different products. That includes the vaccine product at low, high, and mid concentrations, as well as controls to their effect on different organs in the body, including the kidney, the heart, skeletal muscle, brain. Although for purposes of this presentation, I'm focusing only on the results that were generated or from the kidney analysis. We had a panel that included urea, creatinine, total protein, phosphorus, calcium, and magnesium. And from the results shown here, the ranges are comparable, although in some cases they are low, even before the mice received the products, the ranges are comparable at 7-day and 14-day. So we did not see any significant anomaly at this point. We also tested effects of the products on body temperature and weight of the mice. And as you can see here on the left-hand side, we do have pre-vaccination as well as 1 hour post-vaccination at prime dose. And we just see a slight increase in temperature as is expected. Similarly, for the booster doses and 14-day, and the booster too at 14-day interval. We then also tested the effect of the products on normal growth or normal body weight. And so far, we did not see any anomaly. So there was no evidence to support harmful or unintended events regarding these products. We have also ventured initially into binding characteristics, so antibody titers of the products that we generated. And here, for this presentation, we show that total antibody elicited by a chimpanzee adenovector high-dose vaccine construct, both at 7-day and 14-day interval. And as you can see here at prime dose, for both 7-day and 14-day interval, there is a slight increase or more antibody concentration at 14-day interval. Similarly, for the booster dose 1, we see a higher antibody concentration as compared to 7-day, as well as the booster dose 2. We have currently also conducted the neutralization assays. However, these results will be shared later on. Additionally to funding from Government of Uganda, we have also been lucky and we've received funding from UVRI, that is the Innovate UK. And here we were to develop a vaccine towards Chromium Congo hemorrhagic fever vaccine. Uganda has intermittently had these outbreaks in the recent years, majorly around the Kato Corridor region. So what we've done is we've designed immunogens, a total of 6 immunogens, where we've worked with the genome of Chromium Congo hemorrhagic fever vaccine. Of course, I'm happy to report for the genomes we've received from Uganda, these were provided by Professor Emma Thompson, through her collaborative work with Uganda Virus Research Institute. So we have focused on the glycoprotein as well as nucleoprotein regions of these genomes, and we have, focusing on the glycoprotein, we have created a chimera of several epitopes, put these together, and then for the nucleoprotein, we've worked with the consensus region at global level, as well as for those that were circulating in Uganda, the entire nucleoprotein. We've also, of course, subjected the designs to advanced bioinformatics tools, including 3D, galaxy refinement, as well as in silico binding assessments. This is to inform that the designs are almost accurate, although these will need to be validated by the wet lab assays. We then sent our designs to GeneScript for chemical synthesis, and these have been sent back. And this is the cloning strategy that we have used to ultimately insert the immunogens we have designed from GeneScript into the adenovector backbone that was previously generated during the COVID-19 project, vaccine development project. I'm happy to report we have done some sequence confirmation of our constructs, as shown at the bottom there, using Oxford nanopower technology. And currently, we are through the collaboration with Makerere University. These are undergoing preclinical studies, and we're hoping the results will be positive. I will now move quickly to the inactivated vaccine platform. This is led by Dr. Jennifer Seranga, and so I'm making this presentation on their behalf. So this is the vaccine development overview. Step 1 is isolation and production of the virus stocks, and samples are collected all the way from human beings. So during the pandemic, Dr. Jennifer and her team were working tirelessly to collect samples and then isolate and culture them in Vero E6 cells. The challenge we had during the pandemic was accessing these Vero E cells, so it did cause extended delays to the research and development of this platform. And then this step is followed by virus inactivation and verification, where again here, during the pandemic, it was extremely difficult to come across the beta-propiolactone reagent, which is key in the inactivation of the viruses. And this also contributed to the delays during development. However, these did come through, and the group was able to move to step 3, where the inactivated virus was concentrated, and then using ion exchange chromatography was purified and this works on size exclusion principle. And then an adjuvant was added, and they formulated the vaccine. They've also since completed the pilot studies for, I think, pilot 1 and 2. And here is a summary of the laboratory procedures and some of the results that they have. This is the uninfected Vero E cells as viewed under microscope, and then this is how they appear when infected. These were sequenced to ensure that the subtypes correspond to what was already isolated, and then these were purified and confirmed using Western blot technology, and then concentrations were determined, as these are key in enabling one, determine the concentrations that they will work with during preclinical studies in mice. So the pilot, or the initial preclinical pilot, was for safety and immunogenicity, and they used the 28-day interval as well as 40-day interval, and the treatment groups included high antigen dose with the adjuvant, additionally high antigen dose in the absence of an adjuvant, and then low antigen dose with the adjuvant and in the absence of one, and then the control normal saline in the presence of the adjuvant and in the absence of the adjuvant. From the results, antibody responses are shown here. The best performance was from the low dose regimen with the adjuvant, as highlighted here. The team also conducted vaccine safety surveillance, and they worked or monitored several parameters, including body weight, behavioral studies, respiration, ambulation or paralysis, and dermatitis, as well as dehydration. From the results they have, after subjecting the animals to the different products, there was no significant safety issues observed working with this platform. I will now move to the messenger RNA vaccine platform. This is headed by Professor Pontiano Kalebu as well as Paul Kato. Paul Kato is a PhD student and has recently submitted his thesis. So this started slightly before the COVID-19 pandemic, and it was funded by the UK government, UKRI, Engineering and Physical Sciences arm of UKRI, and initially started with training of Paul at Professor Robin Shattock's lab at Imperial College, and then upon his return in Uganda, it involved the setup of a laboratory, and here key equipment had of course been procured also as well through the government of Uganda. So we have a lab that has been set up. However, unfortunately, due to COVID-19 pandemic, the mini GMP facility that was supposed to be constructed as well was not completed, as resources were diverted towards the COVID-19 pandemic. This is a summary of the messenger RNA vaccine development pathway, and here we are looking or considering an HIV vaccine pipeline. So probably the team started with DNA sequencing of the envelope antigen, cloned this in the pDNA vector, linearized it. Transcription was conducted to result in messenger RNA, which is capped and then transfected in cell culture. And we have all these infrastructure at the UVRI and MRC. For ELISA, currently we are working with the ELISA platform as well as Western blot. However, we would need to transition to an electronic microscope, which would be able to bring out the 3D or HIV native structure for the proteins, as well as a surface plasmon resonance equipment, which would be key in determining binding kinetics, specifically of the immunogens, as well as the broadly neutralizing antibodies. This is then followed by assessment of the immunogens. Again, as Adrian highlighted, for messenger RNA platform, they normally use the lipid nanoparticle formulation. And of course, preclinical studies in mice following by analysis in the laboratory. So Paul, in addition, has had extensive training with the Antibody Research Translational Center in India, where he worked with both the messenger RNA platform as well as the self-replicating RNA platform, and worked with the BG505, which is a SOCIP trimer that has previously been designed and tested through other collaborative studies. He was able to conduct this analysis working with a team in India as well as Western blot and also additional binding properties of the BG505 SOCIP on PGT145, broadly neutralizing antibody. He since returned to Uganda and continued with his PhD project, where he focused mainly on Rift Valley fever. And here he introduced mutations to the RVFM segment. And the point here was to increase expression so that this would ultimately result in more immunogenicity. He has also conducted preclinical assays for the immunogens that he has designed for Rift Valley fever. This was done at Imperial College, and he tested the wild type at varying concentrations. Additionally, the immunogens he had designed and included the negative control. And here we see specifically antibody responses to IgG, as well as on the right-hand panel, we see neutralization. Yeah. He has also had the opportunity of transferring this to Uganda, and he has done some preclinical studies at Makerere University. However, the data has shown a stronger response to the humoral arm of the response, and he needs to improve the design of the immunogens for cell-mediated immune response. The key responses or next steps, the key next steps following this work that has been done by the three platforms is to conclude or finalize the preclinical studies, and then for the COVID-19 vaccine candidates that have been developed, we plan to also complete the animal challenge studies at some point this year. The midterm plans at a national level would be to have mini GMP facilities that would allow us to make that key transition from preclinical studies into humans, at least to phase 1, before we can explore collaborations and, collaborations for massive production and additional phase 2 and phase 3 studies. Our vision for these platforms is to participate or contribute to vaccine discovery for infectious diseases of priority, and of course emphasizing zoonotic in nature in Uganda. We also plan to train a critical mass of multidisciplinary team of highly skilled scientists in vaccine development, and then enhance laboratory capacity, equipment, and infrastructure for comprehensive and sustained capabilities in vaccine development in Uganda. I would like to thank the teams, the adenovector team for COVID-19, as well as the CCHF team, the inactivated team, and messenger RNA team for all your hard work in the research and development phase. And then we acknowledge our funders, the Uganda government through Science, Technology and Innovation Secretariat, Office of the President, UVRI, both Innovate UK as well as Engineering Physical Science Research Council, the key institutions, Uganda Virus Research Institute, the MRC, UVRI, London School of Hygiene and Tropical Medicine for supporting this work, and our key collaborator, Makerere University, for supporting our preclinical studies. And thank you all for listening.
Thank you so much, Sheila. Really great talk. I'm going to be really rude and take the first question again. So you've highlighted 3 different types of vaccine technologies. For the next transition, moving into GMP, do you think there will be any commonalities or differences across the challenges you might face?
Yeah, sorry. Thank So far, these are different platforms, and then to make that transition, we are all facing similar challenges. It is extremely expensive. I attended the biomanufacturing training at Oxford University, and I had the opportunity of visiting your GMP facility at Oxford University. And it's extremely expensive to have this set up. That is why we are hoping we can have at least mini facilities set up. Our colleagues at Makerere University, I did not highlight this, however, they've been working on the subunit platform. So we have all data from preclinical and are just hoping funding will be available to allow us to make that transition. Yeah.
Thank you so much.
Yeah.
If there are no further questions in the room, I think we might be to a coffee break. Is that true? Sorry, there is one question. Sheila, sorry, you nearly escaped.
So excellent presentations, and I really enjoyed the capacity shown from Uganda and the African continent. So my question is really community-based. You know, one of the things that we're facing with the US presidential order is people's lack of confidence in the abilities. So what messages are you giving, if any at all, to the communities on the work and the development of vaccines platforms in Uganda and the collaboration? Is there any work being done to create that awareness so that there's an understanding that, you know, there's capability, there's skills, and there's capacity in the African continent? Thank you.
Okay, thank you very much. That's a very important question. So Nambusi, you will supplement. However, for now, I just wanted to highlight that at the MRC and the UVRI, we have a strong social science department. And of course, there are already interactions ongoing for vaccine development projects as well as other research to engage the community. However, for the Chromium Congo hemorrhagic fever vaccine study specifically, we did have a stakeholder meeting or a launch where we invited key stakeholders from the community, including policy, community members, religious leaders, and study participants, as well as regulatory. We introduced the proposal from the beginning, had key discussions which have been summarized, and we hope in the course of the research we shall provide them with regular updates. Nambusi, over to you first.
Thank you, Sheila, and thank you very much for the question. I think it's a vital question. And as Sheila says, within the unit, we have an integrated social science component. Our colleague here, Dr. Agnes Sally, will be speaking after the break about some of the unit's work on social science and how individuals in the community are understanding vaccines and vaccine research. Unfortunately, because of the time available, she won't be able to do justice to the breadth of social science research. But one other thing I would like to highlight is a colleague of ours is doing a study in 2 different communities in central Uganda, and he's specifically looking at community perceptions about a Ugandan-made vaccine. So we know that we are going to get there. We're in the process of developing Ugandan vaccines. Will people take them? Will they trust them? What do they think of them? Is it a nationalist source of pride, or is there concern that it might not really work and they'd prefer to go with the vaccines from the countries that have traditionally been developing vaccines? So we want to get ahead of that and ensure that we are communicating what's being heard in the community with the vaccine makers, policy makers, and so on. He's at the stage of analysis, so we're really keen to see his findings. But as I say, that's a really important question and one that we definitely have on our radar to really boil down to.
I'm going to make a recommendation, and that is that it's really important when we're doing this sort of basic science presentation to include that work that you've just described, because otherwise we're appearing to have a disconnect with the behavioral social science community and the basic science, and that's what's causing issues in our communities. And there's a sense of unethical work, but we're actually doing very ethical work from an African continent point of view. So I strongly recommend that we include that in this sorts of presentations moving forward. Thank you.
Thank you very much. And yes, that's a very important point. I'm sure a lot of the people applauding are the other social scientists. But no, it's a really important point. That's why we do have a presentation. But we also wanted to give Sheila the time to really sort of showcase the work that's being done. But thank you. That's a really good, important suggestion. Thank you.
So I think Sheila deserves another round of applause. And I believe we have 30 minutes for a coffee break.
We would request that we still come back at sort of 20 minutes, so at 10:02, as in the program, just in the interest of time. We're trying to ensure that we catch up as much time. Let me just check I haven't said the wrong time there. Yes, at 15:50. Please, let's come back at 15:50.
Enjoy a quick coffee.
Thank you. And you can please, if you'd like, to bring it back in here. So I don't know how hungry or how decaffeinated everybody is, but do please bring it back and drink it here so that we can start on time and catch up. There will be a really exciting entertainment towards the end of the day, so I would hate for people to miss that if we're running over. So please do bring it in here for the tea. Thank you. And thank you so much, Gina, and we'll speak to you later. Thank you so much.
peer-to-peer important in really beefing up what we want to do. So we've learned that there is no way you can bring vaccines without actually causing people to understand. There's a study I haven't talked about, and I think I mentioned it in passing, that is the schistosomiasis community study that we did. This is where we actually sat with the communities and discussed the information documents. We shared the information about schistosomiasis, and they gave us what they felt. They told us about their fears, and that is just in preparation for the development of the vaccine. So a lot of work is going into this, and I'm glad that many of our unit scientists are engaging and trying to ensure that we get formative information about these studies. For the second question, are there HIV plus other infectious diseases screening programs that can be accessed in local communities? That's a little difficult, but I know that I don't know whether there's another scientist who wants to explain that, but I know that in all our communities where there's HIV work, there is always that HIV clinic where people can be assessed accordingly. Any of the scientists wants to help me? Dr. Ubaldo, you've had a lot of experience in this work. I would want you to help me answer this. The question is, are there HIV and other infectious diseases screening programs that can be accessed in local communities? Dr. Ubaldo. I picked on him because I've worked with him many years, and he has done a lot of work in HIV.
Yes, there are the routine HIV screening programs that are available in the different health facilities, from Health Center 1 to Health Center 4, up to the higher hospital levels. I hope I've answered the question.
Thank you. We hope the person who asked that question is happy. Thank you.
There seems to be a hand out there. Oh, hand, okay. Two hands. Quick in summary, we're running out of time. There are those two hands.
Good evening, everyone. Thank you for the wonderful presentation. My question is regarding the attitudes towards vaccines and the general, I think, view of vaccines in the community. I noticed that most of your studies were community-based. I don't know if there are any studies by you or any of your colleagues to address the misinformation that goes on, like on social media, and if there are any efforts with the government to try and reduce the vaccine misinformation that goes around on WhatsApp and other media in Uganda.
Thank you. There's quite a lot that is also coming into the social science world because of what is happening. For example, for the maternal vaccine studies, one of the things that is happening is like every week we have a team of social scientists who are trying to pick every bit of information that is coming through the social media to try and ensure that we get answers for it and we understand what is happening. And I think the PrepVac, I think, also had that, and that's why they had what I put down, that they had structured, they were getting information, and this information was being fed back to the main clinical teams. And that is one way that we are trying to ensure that what we are having is actually getting back to the teams and also supporting through the community advisory boards where we share what is happening in relation to different studies. So it is like you are doing the research, you are really implementing, but at the same time you are keeping a close relationship with the community advisors and also getting their view of what they are finding, but also in some of the studies we are practically saying, let's look at the news, let's look at social media, what are the things that are threatening people around vaccination, particularly for the maternal vaccines.
Thank you. Finally.
Yeah,
Thank you, Agnes. My name is Jolene from the Welcome Sanger Institute. Thank you for your wonderful presentation. I just wanted to find out, how does limited or lack of vaccines impact vaccine hesitancy or lack of trust towards vaccine? So I say this because I saw you, you said there was like yellow fever vaccine hesitancy study that you're doing, and I also saw that long waiting times, people tend to, be discouraged and go back home. But is this a big problem, and how do you go around that? And this is bearing in mind that, there's only, for example, when I was in Kenya, there was only one vial of yellow fever vaccine in the whole country. So how does this impact vaccine hesitancy more broadly?
Thank you very much. I think the issue of vaccine hesitancy is very much a point of discussion, because we need to also look at some of the issues that cause hesitancy, because we are trying to understand hesitancy in the right way. Because you may think somebody has hesitated, but it's basically because they cannot access, and therefore they miss their vaccine. For example, I think, I don't know whether I gave an example, where somebody goes to access for a vaccination and they have to wait. And even then when they wait, some are told to go back, maybe because there's a stock out. So we need to understand hesitancy in a very serious way, because sometimes what we may call hesitancy may not actually be a hesitancy, it may be lack of access and things. So that is an area for us as researchers to continue exploring and breaking down what exactly is hesitancy. And I'm glad that the WHO has a framework that is really looking at the behavior and social drivers and trying to bring questions that really dig deep for us to now start picking what is actually hesitancy, what is actually lack of access. And so even this one, the yellow fever study that you've mentioned, the student is interested in knowing why in that particular place, it is in Mukono, why people are actually not as eager as it has always been to go for these vaccinations. Some literature has mentioned a bit of, since the COVID came, there's a bit of hesitancy, but then that doesn't explain the whole story, and that is an area of research that we continue to explore. I hope I've answered you, but we can even have a one-to-one. Thank you.
Okay. Thank you so much, Dr. Agnes, as she sits down. Okay, our final presentation for the day is by Dr. Primus Chai-Ching, Understanding Participants and Public Perspectives on Vaccines and Vaccine Research, a Perspective from the Region. Dr. Primus, you're most welcome. Where is Dr. Primus? Welcome. You will help us. That name, I don't know whether I pronounce it well. Is it Chai-Chi? Chai-Chi. Chai-Chi. Dr. Chai-Chi. Welcome.
Hello everyone, and thank you again for the organizers for the opportunity to share a bit on what we have been doing on vaccine and vaccine research. My presentation will focus a lot on what we have done in Kenya. And I think the earlier presenters have really given a good background on the importance of vaccines, so I won't spend much time on that. With respect to the plan of my presentation, I will also focus a bit on a few case studies, and I will focus more on the key findings we've had from those studies, but I'm happy to engage with the audience on more details about the studies. Yeah, so not so much to talk about this. Vaccines are great. They do save lives, and it's something which is universally known. And when it comes to public views about vaccines, they are really informed by lots of things. It could be shaped by social setting, behavioral, cultural, and even psychological factors. And public perspectives on vaccines and vaccine research can be explored using a wide range of approaches, ranging from a quantitative to qualitative approaches, or even mixed methods approaches. As I've mentioned, I will pick 3 key case studies that my team has been quite involved with, and some will focus on vaccine research in the context of clinical trials, and others will focus more on vaccines per se within immunization programs. So the first case study I want to highlight is on views around controlled human infection studies. And these are studies that involve deliberate infection of healthy volunteers. And most often the idea is to understand interactions, host-parasite interactions, and also to test for vaccines and at times drugs as well. So we have an ongoing study. This is a program of work that we are doing in Kilifi. We've been doing it for the past 7 years, looking at social, ethical, and regulatory implications of such studies on our side. So for this case study, I will just highlight a survey that we have done with study volunteers for this study. And this has involved surveying them prior to joining the studies and also after they have left the studies. And the idea was to get their motivations for joining such studies and even the extent to which they consult their significant others as part of decision making, and also the role of a compensation in that equation. So this is just a bit of demographics of for one of the studies we have done, and we find that most of the volunteers who join these studies are men, and again, most of them are married, and we find that the average age of the volunteers is between 26 to 30 years, and they often stay with at least one child at home. And the reason why I highlight these issues is because it affects how people respond to the studies, you see. When we look at even their research experience, we find that about a quarter of them have had at least some experience in past research, you see. So this slide just highlights the key motivations for participation. And here, for most of the people we have engaged with in the past, many people thought that the primary reason for joining such studies is to get compensation, which most often is like $20 for an overnight stay. And the volunteers could stay between 25 to 45 days in an inpatient facility. But what we find here is that while compensation is an important motivation, they are still really keen on the level of screening that they get prior to joining, because they do a wide range of tests, and these tests are not even found in the hospital. So they see it as a way of just making sure that their health is in good order. And many people also understanding that malaria is an important infection in their setting, they are really pleased to be part of a research that can contribute to vaccine development. And on this slide, I just want to highlight again, we actually ask questions around, in the event that there wasn't any compensation for this study, will you still participate? And what we find is that there are still many people who are still willing to participate, even without the compensation. Although we realize that the proportion of people who want to participate without compensation actually reduces when they have gone through the process of study participation, and it may just reflect how intense the procedures are as well. And some other thing we also explored is the mode of disbursing the compensation. In the earlier studies, this has been given as a lump sum at the end of residency, but over time, the PIs decided to have it as weekly disbursement, and we also inquired which options they preferred, and what we learned is that there's a preference for weekly disbursements rather than the lump sum that is done at the end of residency. And again, assessing what they think about the appropriateness of the amount, we find that most of them think it is fair. And again, after a participation, the views shift a bit. We find that after participation, there are some people who think it is actually poor. You see, there are a higher proportion of people who think the amount should be improved. Here. With respect to the extent to which volunteers consult others, we actually find that most people do consult others as part of the decision-making process. And the predominant categories of people who are consulted include spouses, parents, and even friends and former study participants. And we find this interesting because even those who are married, they still consult their parents. And it's quite interesting. We think they are independent, people who can take decisions, but still, we still find that strong a connection of family as part of decision-making process. And we've also looked at the extent of support that they receive prior to joining the studies and even when they are in the studies. And we find that there's also a change over time based on the category of group of people who are involved. So the next case study I want to talk about is also something around vaccine donation, public perspectives. This is a study that is funded by the NIH, and those are the colleagues that we worked with. It mainly focused on getting public perspectives on vaccine donations, especially in the context of an epidemic or pandemic. So overall, the aim was to explore the ethics of vaccine donations, especially from high and middle income countries to low income countries in the context of epidemics and pandemics. And for this, I will mostly talk about what I've highlighted in red, that exploring the views of key stakeholders on the potential benefits, unintended negative effects, and ethical issues around vaccine donation. And again, we used a wide range of approaches, including document reviews, interviews, and focus group discussions with a wide range of stakeholders. And some of the issues we find, which also raised the nose with what Agnes spoke about earlier, we find there is quite limited awareness about the extent to which the vaccines were actually donated. It was interesting that even right from the national level to the local level, most people, even guys who sit even in the technical working groups, they couldn't say for sure whether the vaccines were donated or not. And what they were more interested in is that at least we have them. So I think that is important. Whether they are donated or not is not so important for us. And there were some who felt that, considering the fact that as a country, especially for the EPI vaccine, they have mainly been donated in the past, they were not surprised if the COVID vaccines were actually actual donations. Like you see the second quote down, it says, "To my knowledge, I don't think the government has ever bought vaccines. We have been getting donations from developed countries or from agencies in the developed countries." You see, just highlighting the fact that there's a belief that vaccines, we don't buy them. There should be donations. And again, it takes us back to the discussion we are having are we ready even as a continent to be manufacturing our own vaccines? Yeah, and if this is the position we have, is there any motivation for manufacturers to even get into this space when they're not sure if they will make money out of it? You see? Then again, some other things we have seen is we actually inquired what do they see as the perceived benefits of the donations. And again, issues around the fact that there was a broad understanding that the donations actually contributed to reducing deaths from COVID, as well as protecting the population from adverse events as a result of the disease. Still, there were many who felt that the donations actually helped the countries to ease the lockdowns that were all over the place, as such reduce the economic impact of the lockdowns. And other issues that came up were the fact that the donations were also used in other aspects of the health system. Still, yeah, but we also found that when we inquired about them, why they thought these donations were being done from the developed countries to the low-income countries, there were lots of views as well. There were those who felt that there was that genuineness in trying to save lives, and others felt that as a country, Kenya was a strategic country for most Western countries. As such, they wanted to just help the country because it also helps them in their other diplomatic activities within the region. Like you find on the last quote down there, it mentions that it may be because of our strategic position. If you look at Africa, Kenya is a very strategic stepping point for Western countries. So perhaps it was a win-win situation for the donors as well as the recipient countries. So, but there were many people who also were a bit sinister. They didn't think it was genuine. So there were many people who felt that it was just a way of dumping vaccines that they didn't need, especially towards the latter end of the pandemic, where there were lots of donations that were not used, and at the end of the day, they got, and some have had short half-lives, and were eventually got expired, and it was now a challenge even for the country to dispose them. Yeah, and others felt there may have been other things. Perhaps they want to use it to finish the population of Africa. Yeah, so again, it's feeding into the whole issue of ROMOS that we have seen in the earlier presentation. Then we also inquired about the unintended consequences, and again we find issues around, there was a feeling that there was a general lack of sensitization. And the idea was that most governments were just keen on doing mass vaccination, and the result was that they didn't pay much attention on sensitizing the population on the importance of this, and this really generated a lot of rumors. And again, one of the fallout was issues around hesitancy to take up the vaccines. And again, there was a feeling that there was, as a country, we didn't pay much attention on picking up the adverse events from the vaccines, because again, we were just focused on vaccinating as many people as possible. See. And the issue of waste also was also something that came up, that we took more than we could manage. As such, we ended up wasting some of the vaccines. Like we find also in the quote, the first quote up there, it says, we shouldn't have accepted these many doses to come to us. Probably they could have gone to another country to also assist, rather than coming to Kenya. Then now the vaccines will have expired. And indeed we had lots of expired vaccines. as a result of inability to handle the volumes. And the last case study I want to highlight is that of one of my master's students who is submitted a thesis at the Liverpool School of Tropical Medicine, still looking again at the effects of the COVID mitigation measures on routine immunization programs in the country during the pandemic. And this was basically a qualitative study that involved interviews and focus group discussions with parents and guardians of small children. She also looked at the vaccination cards to also see the extent to which the vaccines that were taken were well documented. So again, just a flavor of some of the things that she found there. We found that there was an issue of closure of lots of health facilities. And what that meant was that many parents and guardians were not able to access vaccine because all the focus was geared towards COVID at the detriment of other health services within the health facility. And linked to that again was the issue of health workforce. We found that there was quite a shortage because lots of health workers were not working. Then the few that were there, all the energies were focused again towards COVID. And as such, having access to them was a challenge. The third issue I want to highlight there was issues around stock out of vaccines. And again, still linked to the whole focus. The health system was all geared towards the COVID. And as such, other services were not, even with a shutdown, also vaccines were not coming into the country, and that also affected access as well. Then those who also went to the facilities, there were times that they had to there was additional cost to get access to this because they had to go to the facilities at times, multiple times, in order to get vaccines. Or at times, you go there, the health providers are not there, you have to go back and come back on a different day, or still, you go there and they tell you you need a mask to put on before you get in. And at times we say masks are cheap, but for really rural people, it can be quite an additional cost for them. See. And some, once they can't buy the mask, the mother just goes home with the baby. See. And again, we find issues around, these are even in regular time, issues around the number of people that have to be there before the vaccine vials are opened. So once the system has been sending away people so often, then even so fewer people come. So if you're not up to a number that is required to open the vial, so people come and still they can't have access to the vaccine, you see. Then cases of concerns from the health providers themselves, where the mothers and the guardians come and there is a demand that if you're not vaccinated, we can't even see your child. Also, it raised a lot of issues. Those who didn't want to get the vaccine, what happened was that they just went home with the babies, you see. So they didn't have the babies vaccinated. Then the issue of male involvement also is also one thing that we noted. And here, men were more involved. And the reason was that the men now were more at home. So this actually helped a bit, even with support that they gave the mothers and the guardians at home. But overall, what we learned from this study is that the COVID mitigation measures really undermine access and uptake of childhood vaccines. You see. And again, the question we keep asking ourselves was, what we did, was it really, the drastic measures, was that really necessary? You see. So, Based on this, again, we see that the public perspective on vaccines and on vaccine research, they are really important. They are critical in gauging public views around vaccines and vaccine research. And this can really provide us crucial evidence on building information to help the public have a better understanding of the science around vaccines. Because at times, even the hesitancy that we talk about is based on the fact that people don't understand the vaccines and how they work. Again, we realize that this knowledge can generate useful information in designing studies. And one way of doing this is, once for vaccine research studies, it's easy if you can pick out the range of burdens, the range of inconveniences. We are able to design studies to try to minimize them, and even the perceived benefits also, we can design the studies to actually improve these benefits, to maximize them. And understanding public perspective on vaccine is critical in designing interventions to improve vaccine access and uptake. And in the long run, we can have better vaccine impact of vaccines across the population. And again, embedding the social science within all these processes can really be a useful approach to learn a lot and improve how the public views this, and even how they take up these vaccines, and even how they perceive vaccine research. And the whole idea is that it can improve, it can build trust, the trust that the public has around vaccines, around vaccine research, and also address the vaccine confidence gap that we are experiencing all over. So just to acknowledge our funders and thank you for your attention.
Wow, okay. Thank you so much, Dr. Primus, for that presentation. Yeah, before we end the day, before we get a summary of what has happened, any concerns, any questions, areas of clarification from anyone? None at all. Thank you so much. Thank you so much for that. We'll call our coordinators for the day.
Thank you very much to the presenters in that last panel. It's my pleasure to welcome Professor Moffat, who will be doing the introduction for the final session. It was a late change to the program, so apologies for the confusion.
Stopped working? Started. Thank you very much indeed. So I want to introduce a friend, colleague, Professor Steve Tolman, who is also a member of our Scientific Advisory Board, and he has been for a number of years. So thank you very much, Steve, for persisting in this role. And it also shows how much we value your contributions. And so Steve is a professor at the WITS in South Africa. He is director of the MRC WITS University Rural Public Health and Health Transitions Research Unit, which is a major research unit in rural South Africa. And Steve has been absolutely instrumental in both developing and running a number of studies, networks that look into transition around health within the continent. And these include being principal investigator for in-depth Alpha Network and others. So for those who are observant who've been looking at the program, you will notice that we are transitioning from infections, and overnight, tomorrow, we'll be talking about non-communicable diseases. So I think it's absolutely fitting that we hear from Steve, and the title of his talk is Mapping Chronic Conditions. So Steve, really, really glad that you're here. I know what has gone in the background for you not to be able to present tomorrow, but as ever, very generous to reschedule your talk and come in yesterday, and you have to dash back tomorrow. So we very much look forward to your talk, and again, thank you very much indeed for accommodating the program that we've had to come up with. Thank you very much.
Thank you, Moffat. It's more than generous. Thank you all. The last thing you should be doing is listening to a talk on chronic disease, non-communicable disease at the end of a very long day that requires you to sit down. I have no problem if you stand up while I'm talking. It would be wise. But in any event, thank you, Moffat, again, more than generous, and such a pleasure being here today. The background is a close family member who will have surgery tomorrow afternoon, and it's simply important that I be there. All should go well, but just to be there. But today, it's been an extraordinary experience. I know that tomorrow will do the same, and this transition, which captures so much, Moffat, also talks to presentations tomorrow that go along the life course, whether it's asthma, whether it's mental health, whether it's diabetes, and we can't avoid that in the continent, the region, the countries in which we're involved. This issue of the transition and the intersection between infection on the one hand, chronic conditions, and so-called non-communicable risk and disease is profound. And I'll share a little. On the one hand, as Moffat says, talking about mapping. Of course, it's from a limited experience. We're all learning at the moment. But at the same time, I thought how to approach this. And as was said in the very early discussion before the tea break this morning, people are living longer. And issues of dementia, which involves changes in ways of thinking, in memory, in scheduling, in executive function, as people get older, are becoming more prominent. And they relate to infection, and they relate to chronic disease risk. And the fascinating thing, reflected in a number of articles, but particularly a recent Lancet Commission on Dementias, led by Jill Livingston, but Nolene Nakasuja was one of the members, emphasizes how prevention can bring terrific returns. And that prevention relates to many of the risks and many of the conditions we put under the umbrella of non-communicable or chronic diseases. And I'll share a little bit of what I'm learning about chronic conditions along the life course, but also from a perspective on cognitive change and dementias. So, depending on sources of data, and we've heard a lot today under the Uganda umbrella of different platforms, including population-based platforms. And because of these effects at a population level, the pyramids you're seeing from the top left is one part of rural northeastern South Africa, southern Africa, and the pyramid you see on the bottom right is exactly the same population only 30 years later. That is how fast change is happening from more classical infection and primarily mother and child to capturing a whole host along the life course, including in this particular population. And this is a poor, rural, border population of South and Southern Africa, and yet we see that the numbers living beyond 50 are very high, and that is even at the epicenter of HIV, then COVID, mental health, hypertension, and a range of epidemics, pandemics, layered one on top of the other. And the experience in East Africa, the experience in West Africa is no different. There are dramatic changes, and the importance of understanding them is profound, because otherwise we fall behind the curve. Services fall behind the curve, work across sectors is behind the curve, and in a sense, investments happen that are not well enough targeted. In this environment, and the dotted lines in fact show the South African national picture, whereas the solid lines show this rural community, so it's not very different. And again, here over some 30 years, if every death in a population sample is counted, you get these impressive curves that can give us a pretty good idea about what's happened with mortality and with life expectancy. And as you can see, the tremendous dip in the middle on life expectancy is largely an HIV effect, AIDS effect, mortality effect, and then the return dramatically fostered by antiretrovirals, but as was said again, the prevalence of HIV, if anything, is increasing at the same time as survival is increasing. And for those nearer the front who can see the little kick, that is a COVID mortality effect. So ask yourself, did COVID have an effect on mortality in rural environments in sub-Saharan Africa? You bet it has. And this is one of the examples in rural South Africa. At the same time, we've talked about the social dimensions. And these curves, much less complex than they look, simply show migration patterns. Migration patterns from rural to urban and back in this kind of Southern African environment. And that whole region is really driven by migration. The story here emphasizes those in blue. What the blue curves are showing is increasing migration among younger adult women as these join the labor force and look for employment and look for income. And you can imagine the changes that are happening in household and family composition, in caring and the like. So these maps simply show, where am I talking about? We're talking about rural northeast South Africa, a former Bantustan, so a vulnerable, somewhat marginalized population with about a third being Mozambican immigrants, initially refugees from the civil war, and now Mozambican immigrants who have intermarried, born children, and that is the community that is here and that has been followed since the early to mid-1990s. That following, along the lines of the surveillance slide showed earlier, also creates a longitudinal platform for a diversity of studies. And this is simply a schematic to show that and to bring out the great versatility that population-based platforms, and of course there are other kinds of platforms we learn from, but population-based platforms are highly versatile in their ability to support various kinds of study designs. We all, in different ways, do trials. But what happens after the trial? And what happens 5 years after the trial? Longitudinal platforms, when they're sustained, and when there are the levels of community engagement we've been discussing in Dr. Agnes, Dr. Chi's presentation, allows that rapport with communities that, again, support the sustainability of longitudinal platforms. I spoke about 30 years of monitoring mortality. What about cause of death? Now that's not so easy because even today, the majority across the world do not have deaths counted. But when we do count deaths, as is the case in some of the Ugandan platforms, this particular South African and other platforms, and then apply means to determine a probable cause of death, these are based on so-called verbal autopsies, we find that the black mountain of deaths from HIV/AIDS, which you see in the middle, is increasingly paralleled by deaths from various non-communicable causes. And it is that intersection that is part of the transition that health and social sectors, as well as the various health and medical disciplines that we cover, need to engage. If you look at the second bar to your left, those are the 50 to 60-year-olds. Causes of death among well-characterized 50 to 60-year-olds simply shows in the red the mortality from HIV and AIDS, and in the dark blue, the mortality from cardiovascular causes. They are almost equal. And that was certainly in this context what was highly influential, along the lines Moffat was saying, highly influential in the way that we thought about our research priorities. There's a tendency, and I don't think it's in this room, there's a tendency to see older people as somehow consumption with regard to investment. Yet without that older generation in HIV environments, the issues of fostering, orphanhood, childcare, care of older children going to school would have been drastically below what it has been. And so the social fabric has depended very, very highly on older folk. I should know, but I don't, what the situation is with social grants in Uganda. South Africa does have an older person's grant. The older person's grant is geared towards family and households, not just the individual, but does and is received by the older women. And the research is highly impactful on the positive effects this has had on food security, on girl children going to school, and related aspects. There's a tweak to this. We're learning that as men are also made eligible at the age of 60, there is a period in which mortality among men worsens dramatically. And we're hypothesizing this is due to the sudden access to resources and binge drinking of various kinds. But there are other ways to think about it. So let's go earlier in the life course. And one of the partners we work closely with within South Africa is a Soweto-based cohort of children and their parents and their grandparents. But what this slide is showing is, first on the left, a young woman at a similar age in urban South Africa and rural South Africa. In blue is Soweto, in gray is this rural northeast, this Agincourt area. 15 years later, one can see the dramatic change among the same age group of young women in terms of their overweight and obesity, and the convergence of the urban and the rural environment. So these are not conventional rural environments. The change which is reflected in the health profiles is following the social and the economic change, and simple definitions of rural and urban are evaporating. And I've no doubt, at least in some parts of Uganda, and certainly across sub-Saharan Africa, that is being played out in different ways. Now, what happens when you're able to link your population data to clinic data? Well, firstly, you learn that there are many people in populations who do not use clinics or who use clinics sporadically and so forth. But in this particular slide, it's simply showing the interplay between those who attend clinics and are hypertensive and those who attend clinics and have HIV/AIDS. This is 40 plus. If you look across the population as a whole, all age groups, in fact, those curves reverse. It's HIV first and hypertension second. And of course, there are many other causes, and this is dynamic, it's changing over time, and the like. We saw, I think it was the presentation just before this, about the way in which COVID affected attendance at clinics. In the upper two curves, what you can see on the left-hand side HIV, on the right-hand side hypertension, and simply a dramatic fall-off in attendance at those clinics. And we're capturing that because the population database is linked to the clinic database. Yes, there are the gaps, but that is showing the trend over time during various levels of lockdown in rural South Africa. Interestingly, because there is a chronic medicines distribution network, in fact, there is some parallel with fall-off in attendance at clinics at the same time as rapid increase in accessing medicines through this distribution facility. It has its own issues, its own problems, but it is very interesting how the two parallel each other. Now, because of that transition, and I've no doubt colleagues think about this a lot, we're dealing with the issue of multimorbidity. Two or more conditions in the same person at the same time. And part of what was said this morning, and quite rightly, is these issues present far younger in conditions of adversity. So those graphs and slides that say this is the picture after 65 or the picture after 60 are really overlooking what is occurring at much younger middle age spans. And in this particular picture, we're showing from rural northeast South Africa that because of this intersection, because of the two conditions or more conditions that are both infection at the same time as being non-communicable, that the classic picture of increasing multimorbidity as age increases is simply disappeared. It's simply flattened. And this plays out whether it's women, men, or whichever self-identification we see. Now, this is not a great slide, but what it's really showing is that in a few centers in West Africa, in East Africa, and in Southern Africa, where harmonized instruments were used with some classic conditions, risks of obesity and hypertension, conditions like diabetes and chronic kidney disease. On the one hand, the hypertension and obesity risks have remained relatively stable in West Africa. But come to the East Southern African picture, there's a significant increase over simply 5 years. On the other hand, chronic kidney disease is pretty significant across all those regions. And it helps us to learn how valuable studies across the region using similar instruments can be, and the importance of knowing and understanding those. Getting back to the middle-aged and older, and one has to say that studies on aging really cover the life course. To assume that studies on aging are simply among older people is to get it wrong. They relate to young as well as middle as well as older ages. And in this particular case, we're strengthening our ability to understand the phenotype through training of lay health workers, through training of nurses, and through different kinds of technologies that we found helpful. One of the key technologies which are likely being used are not just tablets, but finding ways to lower the language and the cultural influences on cognitive assessments of various kinds. And what we've been able to gather is the profound effect that education in the first instance and literacy separate from education has on cognitive function. And you've got to know, education in South African Bantustans is pretty poor. And yet, this plays out no education versus primary education versus secondary and after, in terms of the effects of education, the positive effects of education on cognitive performance and the ability to build this concept of cognitive reserve. Similarly, it's almost a no-brainer, but you can demonstrate that when vision is a problem, so is cognition. When hearing is a problem, so is cognition. And so, again, one simply bringing evidence to a lot of what we instinctively know. Similarly, when communication is good in social networks, that preserves cognitive function. When cognition is poor in social networks, you've got to know that the communications are also low. So there's this inverse relationship shown in the graph where communication is high, cognition tends to be, or cognitive decline tends to be much lower. When communication is low, cognitive decline tends to be much higher. Now, we've talked a lot for all the right reasons about HIV and the evolution. Paula, you were talking a lot about that. We're at a very early stage of trying to understand what is the effects of HIV and long-term ART on various domains of cognition. This is very early work trying to show that relationship with one domain called memory. And interestingly, those on antiretroviral therapy and virally suppressed are not doing badly. And one wants to understand a lot more about that in relation to other domains, orientation, executive function, and so forth. Similarly, as data sets increase, ask what questions are possible through overlaps of data sets. Now, of course, that requires certain kinds of ethical consents. But in this particular case, the novelty was capitalizing, as we were talking, on a cash transfer trial 10, 15 years earlier, and an understanding in hundreds of the same households of cognitive change among older people, and finding, A, that there's a positive effect, in other words, that cash transfer positively affects cognition among older people, and one wants to try to understand the mechanisms, the pathways, but that there's a very direct relationship not only with education, but also with employment and later life cognitive function. And part of the tragedy in South Africa is that largely men were employed. Largely men were employed under the apartheid regime. And that's part of the tragedy in this relationship between employment and later life cognitive functioning. There was a meeting in Nairobi a few months back, and some colleagues, I suspect, were there, attempting to put dementias that much more on the map. I was so taken aback, and I shouldn't have been, at the fact that caregiving was front and center in that meeting. And so the issue of dementia is much more than clinical. The issues of caregiving and support and enabling, and the issue of the caregivers is profoundly important. At the same time, ApoE4 is highly correlated in many high-income societies with cognition and dementias. Is it the same across the continent? Turns out, no, it isn't. That the association of ApoE4, that genetic alignment with dementias, is not really there. And that, in fact, ApoE4 levels are quite a lot higher, but quite heterogeneous across African communities. There was a mention earlier about hemoglobin A1C. There's a poster outside about hemoglobin A1C. Alicia has done work that is showing that the difference in diagnosis of diabetes, and you would have done similar work here, when venous blood is used to establish the glucose level and hemoglobin A1C is used to establish the glucose level, are very, very different. Hemoglobin A1C in our context is diagnosing something like 4 times more than venous blood. And we haven't got it straight yet with regard to hemoglobin A1C. This is wonderful work that involved colleagues in the Uganda MRC unit, UVRI, at the same time as Malawi, at the same time as our team in South Africa, asking the question again, well, you're telling us there's more chronic kidney disease, how do you know? And again, the issue of thresholds, that the existing equations to define glomerular filtration rate are not transferring very effectively to our environments. They are creatinine-based. Cysteine seems to function that much better when tried against a gold standard of iohexol. But this team had really hoped to come up with an African equation that would apply at least to a number of communities. They hadn't got there yet. It's part of the agenda, they haven't got there yet. As well as thresholds and cutoffs, simply the issue of what are prevalences is often not there. As I was flicking through slides this morning, this is quite complex work in our rural northeast environment to capitalize on an embedded cohort of around 5,000 folk, 40 plus, and try to establish dementia prevalence. We came up eventually with a level of around 18 to 20%, and I quickly thought, well, I wonder what's published for Uganda. It's also around 18%, at least as far as it's published. But these things have very wide confidence intervals, but they show already, and in this particular, we're talking 18 to 20% among individuals 50 years and older. So 50 years and older, not 60, not 70. So what do we do? And how do healthcare systems and social systems adapt? And there was a lot of discussion earlier in the day about various approaches. Of course, fixed clinics can do some things and do some things well. But we heard about pharmacies, we heard about community-led programs, and again, there is no doubt that one's going to have to look at innovation. This is an effort to develop a digital approach to depression among adolescents. In a rural environment, they're never going to be the psychiatrists. They're never going to be the mental health staff in the numbers required. And we know that there are societies, including Melanie's here, including in Zimbabwe, Friendship Bench and so forth. But in this particular case, the issue of digital innovations to try to get to grips with peer mentors and related support in depression in adolescents. Similarly, in an unusual example of management of hypertension in an array of clinics improving, over time, an observational study was able to show that actually had a significant impact on particularly systolic blood pressure as well as diastolic blood pressure. And I think the reason it got onto the cover of Hypertension is not because the work was brilliant, but because it's shown so seldom. Here was a good news story. You can actually do it. A very interesting piece of work relates to the salt restriction policies that have been rolled out in South Africa. Now, for a long time, if you'd said to me that the salt restriction policies that have been legislated are going to lead to an impact on sodium excretion and blood pressure in far rural South Africa, I would have hypothesized the opposite. It ain't gonna happen. The truth of the matter is, and it's partly by serendipity, that we had a natural experiment. We had a cohort under close observation that was being assessed for blood pressure and various determinants over a period of time. Urines were being taken from a significant number that could help us get a handle on sodium excretion, and the timing of the cohort linked with government introduction of legislation on sodium restriction. First in 2016, then tightened in 2019, and we know that that was implemented in these rural environments. How do we know? Because we visited the supermarkets. And if you check the statement in that almost unreadable, tiny lettering, the volume of sodium had dropped dramatically between 2013 and 2019. And it's borne itself out in both the sodium excretion, which shows quite a significant difference, much lower, and an improvement in blood pressure. The issues of prevalence of blood pressure haven't changed. Risk factors for blood pressure haven't changed, but the levels have fallen in relation to the sodium restriction legislation across the country. Similarly, we've talked a lot and for all the right reasons about young people, young women with regard to HIV. What about older people? I can't say elsewhere with the same confidence I can in South Africa, but programs on HIV stopped at 49. They simply stopped. Well, no surprise. 50 and above, multi-partnerism is prominent. Acquisition and transmission of HIV are all prominent. And in this particular piece of work, we capitalized on a cohort and introduced a trial focused on self-testing. And again, the hypothesis that this would be receive high take-up certainly was sustained, and at the same time some of the anxieties around depression or other kinds of side effects were not sustained. So this really has contributed to now significant policy on self-testing for HIV, particularly among older people in South Africa. I've emphasized this issue of novel and innovative ways of delivering care, strengthening demand. The issue of the older persons grant in South Africa means that older people 60 plus queue. They queue to receive their pensions at the end of each month, and they now get them on a smart card. And I'm not sure it's smart or not, but of course there are low-priced bulk supermarkets very near where you get your smart card. In fact, some of those supermarkets offer the smart card. So what about the queues? Well, you've got about 10 minutes before people start to move forward, move forward, move forward. But very carefully, we've been able to find with a time series, an interrupted time series, that focusing on older people and their blood pressure management in these grant queues is having a positive effect. And if you can do it with hypertension, what about other chronic conditions? Similarly, we all sit in environments where there's a plea, can we bridge the Western and the traditional connection? And sometimes it's highly motivated, and other times it arouses a lot of concern. In traditional practitioners, hundreds of traditional practitioners, in this environment, HIV levels were found to be very high. To be precise, sometimes something like 6 times higher than in the general population. And it was to do with the instruments used, the scarification, and the like. Pilot work has shown that these healers were completely open to using personal protective equipment, and a large-scale trial is now underway. And similarly, that translates not only to linkage to care, but linkage to care particularly of men, younger and older men, which we've all struggled with. You mentioned Moffat networks, and of course networks are important, and networks can be built up. We have been fortunate that our Department of Science and Technology and Innovation has invested modestly in population platforms across South Africa. That's an illustration of a national network which needs to be exploited as effectively as possible. Similarly, there are colleagues who've been and played a contribution in the building up of an African population cohorts consortium, which is gaining momentum and builds on some of the experience of the in-depth network. And then you have early emergence of networks around cognition and dementias. And although not fully shown here, we can see Kenya, we can see Egypt, we can see South Africa, and there is pilot work underway in Malawi, pilot work underway in Ghana. There's got to be work underway in Uganda that I'm less aware of. So again, if we look at chronic conditions and view that through a dementia lens. This issue of a life course, and as the chair of the National Health Research Committee said right at the start of today, he spoke about all of society, meaning across sectors and certainly across disciplines in relation to the life course. There's continuity. What happens in the young stages influences the middle stages and the later stages, and of course aging is hardly only about older people. These health and social transitions are occurring rapidly, and they can be complex, and they're going to be exacerbated by the funding pressures that have been alluded to. But they must support innovation. They have to support innovation in prevention and care, and many before me today have emphasized that. The critical risks for later chronic disease, including dementias, are diabetes, blood pressure, chronic kidney disease, HIV, and no doubt others, including COVID, tuberculosis, and the various viral conditions we've been hearing about. In other words, you tackle things now as effectively as possible. There is a dividend. There is a dividend later in life. How do we integrate the care and the services? There is some experience, but it's not yet a norm. What are the innovations beyond fixed clinics? And of course, some of that innovation is taking care of digital innovations and trying to leapfrog with some of the technologies that are not just the preserve of wealthier urban communities. Of course, thresholds and cutoffs and the economics, the economic impacts can count significantly. So thanks very much, some of the funders who've supported the work, and particularly I wanted to show some of the colleagues, not because each person is necessarily that important, but really to say that the more we engage each other and support and learn and work and win with each other, the better off we are. Thank you.
Thank you so much, Professor Coleman. I know it's late, but does anybody have any quick questions or points of clarification for Professor Tolman?
We'd be forgiven.
Wonderful, thank you. And on behalf of the organising committee, I would really like to thank you for taking the time to be with us today, particularly as you have other things that you're doing. So thank you so much. And thank you all very much for this first day. We're sorry for the technical issues that have been. It was teething problems, but we are now set going forward. As you will see from the programme, the next step is the poster presentation. If you know you're an adjudicator, please may you go out the door on the right where you'll be able to get your scoring sheets. And please all do take time to have a look at the posters. A lot of them are from early career researchers, and they really are excited about the opportunity to engage with their research. So that will continue until 9:20, the poster viewing, and then perhaps, I shouldn't say this, but one of the things I'm most excited about after that is the cocktail session. During the cocktail, 7:20, sorry, no, not that long. No, 7:20. I saw 19:20, sorry. 7:20 will be the cocktail event, and during that we'll also have an entertainment event, which will be from the Ndere dance troupe. If you've ever been to Uganda before, if you haven't had a chance to go to Ndere, then this is a great opportunity. We've brought Ndere to you, and it's really not one to be missed. That will be held at the poolside, so if we go where we went for the photograph and just continue straight, there will also be people to usher us. You will end up at the pool and the cocktails and so on. So again, thank you so much for all the discussions that have happened today, to all the speakers, to all the chairs, to the keynotes, and to all of you. This is a really exciting time for us as a unit in UVRI, so your attendance and participation is really valued. Thank you.